Okay, so good evening, everybody. I welcome you all for this IORA webinar. We are having a series on these, different important topics of rheumatology. And last year, in the last academic session, we did 3 webinars. And after our annual conference in Varanasi, in this, academic year, this is the first webinar. And we will be having a few more in the coming months. So there's eminent speakers are there for this webinar. We are having 7 talks. The first 4 will be of 10 minutes and the last 3 talks will be of 15 minutes each. So with these few remarks, I'll request our president, Dr. Amitabh Mukherjee, to give his opening remarks. Dr. Mukherjee, please.
Good evening, everybody, for being in our webinar. At the outset, I thank all the seniors who has blessed and my brother and friend Rajesh who has organized this webinar, and blessings from the other founders of IORA. So with these few words, with the keynote, I would request Rajesh to go ahead, and I wish that he will organize much more webinars in future for enhancement of our academic power. Thank you. Rajesh, you can go ahead.
Thank you, sir. So with this, I will start with my talk. So is it visible?
Yes, visible and audible.
Yes. Okay, sir. Side. Yeah. Okay, sir. So my talk is on osteoarthritis, the genetic watch. It's not moving. Okay. So we all know that osteoarthritis is the most prevalent form of arthritis and is a leading cause of adult chronic pain and long-term disability. It commonly affects the knee joints, hand joints, and the hip joints, but most of the other joints in the body can also be involved. Worldwide, currently 15% of the individuals aged 13 and older experience osteoarthritis. And by 2050, nearly 100 crore people are projected to have osteoarthritis. In India, in 2019, around 6.23 crore individuals had osteoarthritis, and it was 20th most common cause of years lived with a disability in India at that moment. There are many risk factors for osteoarthritis, including the intrinsic factors, extrinsic and biomechanical factors, and the systemic factors. Now, the role of genetics is also very well documented in the pathogenesis of osteoarthritis. And the research has also suggested that the large group of the genes, they increase the risk of developing osteoarthritis. Now, pathogenesis of osteoarthritis is quite complex due to genetic, metabolic, and local factors which interact and cause a process of deterioration of the cartilage. Over the last 2 decades, the many genes which are associated with the osteoarthritis have been identified, and it is possible only because of the rapidly evolving genotyping and sequencing technologies. Till date, more than 300 genomic loci have been identified to be associated with osteoarthritis at different joints. Now, studies have also shown that the influence of the genetic factors is between 39% and 65% in radiographic osteoarthritis of the hand and knee in women, 60% in osteoarthritis of the hip, and 70% in osteoarthritis of the spine. Overall, the heritability of the osteoarthritis has been shown to be 50% or more. There are many genes which are related with the osteoarthritis process, including the ones which encode for the collagen extracellular matrix. Then there are interleukin genes which encode for the different types of the interleukins. Then there are estrogen alpha receptor, vitamin D receptor, and freezer-related protein genes, and many more. Variation in one or more of the genes may increase the risk of developing osteoarthritis at different sites and in different genders. Many genes are edited, modified, and synthesized for the treatment of osteoarthritis, but the important ones are the genes which are involved in the convergencies. There's a development of the genes encoding for insulin growth factor, transforming growth factor beta or BMP2, and they have been shown to enhance the cartilage regeneration and repair. Then there is anti-inflammatory gene therapy, as inflammation is the hallmark of osteoarthritis. So anti-inflammatory protein encoding genes, interleukin-1 RA or TIMP1 have been shown to decrease the cartilage degeneration. Collagen matrix gene therapy, there are genes encoding matrix proteins such as collagen or aggrecan, which enhances the synthesis of the extracellular matrix in the damaged cartilage. Fourth is the RNA interference therapy, that is small RNA molecules, they inhibit the expression of the specific target genes involved in the osteoarthritic progression. Now, interleukins, growth factors, and the transfer factors are very, very important for the gene therapy. Now, nowadays, the genetics has a definitive role from the diagnosis to the treatment and to the prognosis of many diseases. Now, a role of genetics in the more than 300 genomic loci have been identified to be associated with the osteoarthritis at different giants. And despite advances, no osteoarthritis genetic study is identified to be associated with the osteoarthritis at different giants. Despite advances, no osteoarthritic genetic study has yet led to the diagnostic tool. There are some predicted diagnostic biomarkers which are RNA based, but a lot has to be done in this field. Genetics in designing the treatment of osteoarthritis. The last steps are taken in the use of gene transfer to enhance the cartilage repair, ligament healing, and restoration of different tissues like tendons and the meniscus, making it an early clinical success for gene therapy. Gene therapy in osteoarthritis is also an emerging tool. Genes can be proficiently transferred to the tissues within the joints by intra-articular injection using an array of variable vectors and strategies. Next. We're not moving, yeah. So, gene therapy helps by enhancing the chondrogenic differentiation of mesenchymal cells by stimulating it to the genes encoding growth factors or transcription factors required for chondrogenic response in mesenchymal cells. It stimulates the anabolic chondrocyte response in damaged cartilage. It inhibits the anti-chondrogenic factors. Next. Now, the gene therapy helps in osteoarthritis by stimulation of the anabolic pathways to rebuild the matrix or the chondrocytes, and it may result in the reversal of the disease. And the gene used here is the fibroblast growth factor 18. Second is inhibition of the catabolic pathway. It slows the progression of the disease and not the reversal. And the gene used here is interleukin-1 RA. Third is replacing the damaged cell or tissues with the cells with or without a matrix. And it is successful for the treatment of the focal cartilage lesion. That is matrix. Example is matrix autologous cartilage implantation. There are two basic approaches for the gene therapy. One is gene augmentation approach. Here, the delivery of fibroblast growth factor 18 and proteoglycan 4 is done to augment the natural anabolic process within the joint and to delay the progression of the cartilage degeneration. Second is gene replacement approach to replace the defective or the absent gene and to counteract the ones undergoing the overexpression. So the genes may be inserted into the delivery vector and administered to the target cells to augment and replace the defective genetic material. Two basic methodologies utilized to transfer vectors into the target tissues. One is in vivo gene transfer. There's a direct delivery of the target genes to the lesion site by surgical incision or local injection. Second is ex vivo gene transfer. It is also known as genetically modified cell therapy. Here the gene transfer takes place outside the patient's body. In vitro infestation of the cells is followed by delivery of cells to the target tissues, and it is more complicated. So cells, they are isolated, cells with the genetic defect are isolated from the patient. They are grown in a cell culture, introduce the therapeutic gene, select the genetically corrected cells and grow, and again transplant the modified cells to the patient. So what is a vector? The gene therapy works by introducing the genetic material into the nucleus of the cell, and the system used to deliver the genetic material is known as a vector. Think of a vector as a microscopic delivery truck that transports the genetic material to the target cells. There are viral and non-viral vectors. Now, viral vectors involves viruses as a genetic carrier, most widely used gene delivery method, high degree of efficiency and specificity. It removes all the viruses' undesired genes and replaces them with at least one therapeutic gene. Single injection therapy may be sufficient to reverse the progression of the disease. Downside is may induce inflammatory response, that is edema and multi-system organ failure, and the repeat injection may lead to immune system enhanced response. There are many viruses which are used like adenovirus, retrovirus, and the lentivirus, but the most commonly used is the adeno-associated virus. It doesn't cause any disease in the human, low immunogenicity, and non-replicating. Now, tissue gene C is a biological drug. It is a mixture of irradiate allogenic primary chondrocytes and GP2293 cells whose gene was transfused using retroviral vector. It is approved for treating patients with the moderate osteoarthritis in Korea, and in USA it entered the phase 3 clinical trials. Non-viral vectors, here the genes are complex to various macromolecules, and it has been shown that impregnating the scaffold with the genes resulted in enhanced chondrogenesis. Advantages are capacity to deliver a large amount of therapeutic genes repeatedly, lower cost, and don't elicit a memory immune response. Disadvantages, low efficiency, toxicity of the individual formulation components, and the short-term transgene expression. Now, Fusion 6 and modified cationic liposomes have so far been utilized for the cartilage regeneration. Fusion 6, it can transfect the variety of cell lines. It is a lip-based non-viral gene transfection reagent. It has 30% transfection efficiency and cell viability is more than 95%. C28 12 cells were transfected with the genes encoding BMP2, which resulted in a significant increase in the type 2 collagen and aggrecan gene expression. Now, modified cationic liposomes are made to facilitate the interaction with the cell membrane to deliver the nucleic acid. So this is a diagrammatic representation again of the viral and non-viral, the vectors carrying the therapeutic genes and in vivo and ex vivo transplantation of the cells. Now, coming to genetics in prognosis of osteoarthritis, again, many biomarkers have been identified for the prognosis, but the important ones are the cartilage oligomeric matrix protein, which is a 535 kilodalton non-collagen protein, which has a strong relation with the incidence of knee osteoarthritis. It is considered as a marker of cartilage breakdown and is being studied as a biological marker in various uses. It has the potential as a diagnostic and prognostic indicator and as a marker of disease severity and effect of treatment. A metalysis of serum C-reactive protein and cartilage oligomeric matrix protein levels as biomarkers for the clinical knee osteoarthritis was done by Jufeng Zhang in 2018 in the United States of America. And the meta-analysis of this study indicated that both CRP and COMP level could serve as a biomarkers for the knee osteoarthritis. Higher CRP and COMP level might be associated with a high incidence of knee osteoarthritis. However, higher CRP concentration was not associated with the progression of osteoarthritis, which was seen with COMP. So in summary, the field of gene therapy is a newly explored horizon and can be revolutionary for treatment of osteoarthritis. It is continuing to evolve and researchers are exploring various avenues to enhance the efficacy and safety of these therapeutic approaches. Developing an advanced personalized gene therapy tailored to the needs of specific individual patients could lead to more effective treatment. Thank you.
Great talk, Rajesh. Great talk.
Wonderful, wonderful, excellent, sir. Very nice.
So, Dr. Manish, it's your turn now.
Yeah. I'll just share. Thank you so much, Professor Rajesh, for a wonderful introduction and brainstorming points which you have mentioned for the gene therapy, and definitely the clinical trial. We're very happy to know that clinical trials in the gene therapy are been going on in Korea. And a lot of things you have already mentioned about the about the chondrocyte, the MSCs, the markers. And in fact, the CRP was a eye opener for us, that because usually CRP, whenever it is increased, we never label it as osteoarthritis. There are so good things which are coming up. Thank you so much. So this talk will be on osteoarthritis. The problems, are these reversible? And I think a lot of things is already been hinted by the previous speaker. I will be just going to a little more microscopic level. Definitely, yes. As already been explained by the previous speaker, it is a progressing #1 arthritis in India, and it will be increasing, as already been mentioned. So definitely the genes, the genetics, and the other comorbidities are definitely influencing the incidence, the pathogenesis for the osteoarthritis. But considering a normal person, a person who is not having any genetic involvement, how usually the degeneration starts? Because we have to understand how the degeneration starts so that we can make it positive, in a positive direction for the regeneration. So definitely the laxity is the first thing with the geriatrics age group, which gives definitely a more goosebumps to the cartilage. The wear and tear gradually starts, and the fibrillation is the first thing, which is which is definitely a reversible thing for minimizing the osteoarthritis. The challenges in osteoarthritic knee are at 3 levels: degenerating articular cartilage, degenerating ACL, and degenerating meniscus. So we have to definitely, when the patient is coming to us with the osteoarthritis, with the radiological changes, which are tremendous, and at that juncture of time, nothing is much in the reversible stage. So definitely the role of exercises and physical therapy is been there, and that we have seen in the field of regenerative science that it is associated technically, and in coming few slides you'll be able to appreciate that how it is technically correlated with the regeneration which is possible at an early stage. So we already know with the regenerative science in the orthobiologics that tendon regeneration and the repairs with the stem cells, with the cellular therapy is been possible. But it is also been emphasized that whenever we do exercises of a full excursion of the tendon and the ligament and the muscle of even a shoulder joint or a knee joint or spine even, at the tendon bone interface, there is a little stress factor which has been there, and as a result of which the stimulation of the cells, endogenous cells which are been there, is activated, and as a result a cycle of a regeneration process start. As already been mentioned by previous speaker about the chondrocytes, I just want to give some more basic information about the chondrocytes, that the cartilage, articular cartilage, as today is the knee topic, so we are discussing about the articular cartilage of the knee. So all these articular cartilage has a backbone, and the backbone is chondrocyte. Now they are from 2 to 10%. So it varies from individual to individual. We are all 7 speakers. Maybe somebody is having 8%, somebody is having 3%, somebody is 2%. It has got an emphasis because it is these chondrocytes which are producing the extracellular matrix, which may be a collagen, which may be proteoglycan, whatever it may be. So definitely the backbone at some stages chondrocyte at a microscopic level. Now, are these chondrocytes are always in the functional form? So it's not like that. If we see the adolescent stage or a young stage of a child where the articular cartilage is having a vascularity because of the epiphyseal growth rate, so here the chondrocytes are more in a replication stage as compared to the adults where the chondrocytes, or rather the articular cartilage, what we call as, is not having a good vascularity, and that is the point. So vascularity in the adults post fusion of the epiphyseal is gone. So now vascularity is gone. That is a big chunk, and as an orthopedic surgeon, we all know what is the importance of vascularity in a bone in a delayed union, in a non-union, and blah, blah, all the things. So after the skeletal maturity, due to the loss of blood supply to the articular cartilage, the chondrocytes are stopped proliferating. And when they are stopped proliferating, so obviously the replacement is also less, although in adults, the limited number of progenitor cells are being there in the articular cartilage. So they are already limited and they can do their job. But unfortunately, because the chondrocytes are also stopped proliferating because the blood supply, so there is a vicious circle which has been created. Now, secondly, in a human body, maybe it's a hair, maybe it's a bone, maybe it's a joint, whatever it may be, there is always a balance between the production and the depletion. So the chondrocytes, which are been there, they need to be apoptized. They need to go back to their soil. So the apoptosis of chondrocyte is continued. No formation of chondrocytes will be there because of the progenitor cells. And as a result, the imbalance has been created. Now here we can do something. Now how we can do something? We can do something with a physical therapy. We can do something with a cellular therapy. So for maintaining a healthy articular cartilage, what we require is a active chondrocyte. And for active chondrocyte, we need a chondroprogenitor cells should be able to replicate, should be able to do the jobs. And that can be done by a physical activity simply as a brisk walking. It has been established that if you're going to do for brisk walking, up to 20 to 30% of the cartilage can be regained. And that has been proven proven in the science. Or the second way is the cellular therapy. Now, it does not mean that in osteoarthritis, you require a cellular therapy, you require a brisk walking. We are just talking about grade 1, 2 initial stages of osteoarthritis, where definitely a role of brisk walking has been there. But if you're asking for a grade 3 to 4, a brisk walking is not going to do anything because here already they are in the denuded state. Similarly, the cellular therapy is of no use at that state. So brisk walking, that means you're stimulating the osteoblast, even the subchondral bone, which is very important. I think the heart of a regeneration is nowadays a subchondral bone. The soil should be good, so the cartilage would be good because it is already supplying its vascularity, the nutrition from the subchondral bone, and unfortunately, the cartilage is not having a vascularity. So hypertrophy of chondrocyte is definitely beneficial for the knee joint, but how it is going to be there? By a brisk walking at this juncture of the time. Now coming to the second thing, which I've already mentioned, a heterotropic tendon bone insertion, osteotendinous junctions, where the exercises simply by stretching these junctions, they are being stimulated, and as a result, growth factor secretion from the cells which are there, more activity would be there, and definitely the fibroblast activity or regeneration of the ligament happens. It is just like a same thing. If a partial ACL tear comes to you, you want to immobilize it for a 2 to 3 weeks of time, and then good physiotherapy. The good physiotherapy is going to give it. It's stimulating the fibroblast activity in this manner. Now, definitely, yes, cellular therapy is an option in which ideally it should be a mesenchymal stem cell therapy. But because of the regulatory issues, at least in our country, we are not able to promote it or not able to do it, truly speaking. And definitely, yes, a bone marrow concentrate, MNC cocktail is definitely a better answer as far as the cellular therapy is being considered. But that is only being useful in a early osteoarthritis stages, not in a grade 3 or 2. And that is also with a flat. Why BMAC therapy? Why not a mesenchymal stem cell therapy? Because it is autologous, no chance of rejections, it is safe, no ethical issues, and it is in a permissive category of to be used if being done with the proper guidelines, with the proper consent and all the things. What is good in the BMAC therapy? So the previous speaker was telling about the gene therapy, which is more, a little more away from us as compared to the BMAC therapy. Now, what is happening in a BMAC cocktail is it's a mixed cell composition, having a mononuclear cells, even hematopoietic stem cells, very less mesenchymal stem cells, practically no stem cells, truly speaking. Then how they act? So they act by a paracrine effect. They go inside the joint, they release the growth factors. These growth factors will stimulate the endogenous progenitor cells, whatever lying down there, just like you are making a brisk walking, it is again the same thing as a paracrine effect. And as a result, the regeneration may happen in early stages. Cold centrifuge machine is the best way to have a BMAC preparation. So these are some of the pictures. But now people ask many times that how this stem cell therapy, cellular therapy, mesenchymal stem therapy act. It is simply a thing just like I want to explain. If you have a sore throat, you take antibiotic, it locates to the tonsil. Similarly, if you put a BMAC, bone marrow concentrate, or MSC, which has not been allowed. I'm not saying about the PRP because PRP is little, it's a little down thing. And I think in our official group, we were able to see what the reaction is being done by the PRP. It's been misused totally as a sense for osteoarthritis, truly speaking. So whenever a bone marrow concentrate or a mesenchymal stem cell reach to the joint, what they do, they're able to localize the damaged area. So they're not going to convert into chondrocyte, but they're going to produce a growth factor to stimulate the cells there. And it is just like, a mechanical stimulation, which I have mentioned it here. And as a result, the repair will occur. But definitely not in these knees. In fact, not even in these knees, which are progressing toward arthroplasty. But definitely, yes, even in these knees, they do the changes, which are appreciable. But it's not a total solution. Only you're going to delay the onset. For example, in this case, you can see a very bad knee, not a case for a cellular therapy. It was being given, a regeneration is being noted here, but it is not a treatment enhanced, but definitely it works. So that is a evidence base which we can work it up. We are not discussing about the level of the microscopic level in which we can differentiate it. Lot of publications are there. Altogether, a lot of clinical trials are also being used in osteoarthritis here and outside, and the things are coming up. For example, this work which was being done to prove the cartilage volume increase by giving stem cells. So as I've already mentioned, everything is a paracrine effect which we want to have it. Similarly, degenerating ACL can be fixed. And that is again the same way that you have to place a cellular therapy or stem cell therapy. And definitely some braces are needed for preventing the extreme movement. And there are the different protocols which has been followed by different surgeons. And here is again a proof that ACL regeneration can be done. So this is not a tear, it is a degenerating ACL, which you can see here. And here we can see a good organized fibers, which is again a proof that it works very well. Similarly, degenerating meniscus. We all know in MRIs, we see a degenerative posterior horn most of the time in the knees. Definitely at that juncture of the grade 3 or 4, posterior horn middle meniscus, we are not bothered because we are not able to, we don't want to do anything for that because the articular cartilage has already been damaged. But yes, it has also already been proved that intra-articular injections of MSCs, publications are from MSCs, not for the bone marrow concentrate. They have a significant regeneration of the meniscal tissue in human clinical trials. But ideally, all these cases are grade 1 or 2. So, and definitely, yes, MRI is a good part, which you can prove it up by a cartilage good mapping, in which we can create and make a evidence-based type. So this is my last slide, which I want to emphasize again. So you have two modalities for your early osteoarthritis. If it is very early, you can go for a brisk walking or the exercises, which has got a role in our professors, our teachers, our ancestors, why they were, placing it, yes, and it has now been explained and, with the science. Similarly, your endogenous progenitor cells or the MSCs, even, the synovial fluid, it is having a floating MSCs. Now, we want to stimulate them up. So again, we need a brisk walking, or you can place a PRP. Even a PRP may do, but actually it is in great early stage where it is of very difficult to catch a patient, truly speaking. Thank you so much for a very patient hearing. Love to answer any questions in the end. Thank you so much.
Yeah. Thank you, Dr. Manish. Very thought-provoking presentation, and role of exercises has been emphasized very nicely.
Thank you so much, sir.
Yeah. So I think we'll take the questions at the end of the webinar, right, sir?
Sure.
Yeah. So we are also having a, very senior group of, our panelists, Professor S.S. Jha, Professor Dilip Mazumder, Professor Shantanu Lahkar, Professor Chinmoy Das, and Professor N.C. Mohapatra. So we will be taking their guidance at the end. Now I'll request Dr. Madhan Jeyaraman for his talk on changing pathogenesis. Dr. Madhan, your turn.
Sir, kindly allow me to share this thing, sir.
Yeah.
Madan, your face bright. Please make your face bright.
Is it okay? Yeah, very good evening. Today my talk is on changing pathogens of knee osteoarthritis. So osteoarthritis, everyone knows that it is posing a large economic burden on the global healthcare systems, where cartilage degeneration is more than cartilage regeneration. Hence, the deranged quality of life of the affected individuals. Why the topic changing pathogenesis is more important? Everyone says cartilage degeneration leads to osteoarthritis. It is not so. There are various factors. Let's go one by one. So the global economic burden in 2020 is about 595 million people worldwide, accounting to 7.6% of the population over the globe. And the prevalence is expected to increase by nearly 75% by 2050 due to various factors such as aging population and rising obesity rates. When compared to Indian population, 22% of the adult population is having osteoarthritis knees because of Indian culture and the sort of behavioral pattern. And knee OA is projected to rise significantly with aging and with increasing life expectancy. More nowadays, we can see osteoarthritis knee in less than 30 years as well. So, what are all the pathology in knee osteoarthritis? When there is a early OA, when we diagnose a patient with early OA, there are two things to be noticed. One is initial meniscal repair, initial meniscal problem, and hyaline articular cartilage damage. These two things pose a variations in subchondral bone also. So subchondral bone, the pathogenesis is via TGF beta angiogenesis. Then lot of complements and pro-inflammatory cytokines act along with the current degenerations, leading to all these factors. That is synovitis, chondrocyte activation in the form of inflammation signal molecules, matrix metalloproteinases, aggregations. All these things will rise, which leading to high oxidative stress and viability loss. These will go and it will form finally synovitis and cartilage erosion. So this is the one pathology which we all have read till now. Now coming to epigenetic regulation of osteoarthritis. Already the first speaker has spoken very well about the genetic watch on osteoarthritis. Here three mechanisms act. One is DNA methylation, second one is histone modification, and third one is mRNA silencing. All these three will inhibit anti-inflammatory molecules and increase pro-inflammatory molecules. Finally, it results in knee osteoarthritis. And hence it damages the ECM, extracellular matrix, the main material, which is getting degraded, and finally osteoarthritis results. Now coming to neurological theory. This neurological theory says the same thing. The nerve endings, which is there in the cartilage lining, which will get the mechanical stress signals and inflammatory signal molecules, which will also enhances the production of inflammatory cytokines. Hence, osteoarthritis results. This is one such theory. The next theory is nothing but subchondral bone pathology. Yes, subchondral bone, due to chronic traumatization of the knee joint and impaired, everyone knows that cartilage is having a limited potential of regeneration. So chronic traumatization leading to impaired regenerative capacity. Finally, it will impair your subchondral bone metabolism. When subchondral bone metabolism is it's impaired, the limited permeability of biological active substance among the cartilage lining and the subchondral bone. So when there is a nourishment getting decreased between the cartilage and the subchondral bone, hence your cartilage will become dry and it will get calcified. Once this calcified cartilage appears in the joint, the number and functionality of the mesenchymal stromal cells present in the joint surface will get decreased. Finally, it leads to osteoarthritis knee. Now coming to gut theory, there are something called gut dysbiosis. Now the psychological thing and pain pathway we have seen. When there is a distress, there is a when the whole body will go into distress or any oxidative stress, there will be release of cytokines which will reach the brain and it will start giving the altered signal for cortisol processing. Once this cortisol is abnormal in the body, it will go for three things: physical inactivity, muscle loss, and somatosensory dysfunction. All these three things will act together. Finally, it also will result in bone marrow lesions, and hence the effusions will start and leading to osteoarthritis knee. The next one is dysbiotic gut. This dysbiosis, everyone talks about gut dysbiosis. What exactly it is happening? When there is any senescence, the senescence of cartilage is mainly due to dysbiotic gut. There are normal commensals as well as abnormal organisms which will release lipopolysaccharides. This lipopolysaccharides will decrease short chain fatty acids in the body. Hence, your inflammation or oxidative stress will increase. Finally, metabolism disorder happens. That is called leaky gut syndrome. When there is a gut leak syndrome, along with the gut, the lipopolysaccharides will enter the body and it will go to the circulation and reaches the joint. Once it reaches the joint, it will degrade your joint surface. Hence, your extracellular matrix will get breakdown, and finally, cartilage tissue gets breakdown. So, what gut microbiota does? So, the major risk factors will be age, diet, gender, genetics, obesity, metabolic syndrome, and joint injury. So, what all can be given to revert the gut? There are few things called probiotic, prebiotics. That probiotics is nothing but prebiotics is nothing but whatever we have taken in the diet, like curd, spinach, all these things comes under prebiotics. Probiotics, the live attenuated or killed organisms of the normal commensals which will get into the gut and it will increase the gut permeability. And then nutraceuticals, nothing but vitamin D, calcium, free free fatty acids. All these things can be given. Exercise. The main thing is exercise, which we should ask the patients to do. Knee joint strengthening exercise. Hence, it will result in good volume of the knee joint, meaning the muscle bulk around the knee joint. Last one is fecal microbiota transplantation. It is in the research phase. A few clinical trials have been done. From the particular individual, they will isolate the organisms which is coming in the feces. They will multiply the organism and they will be giving back to the patient. So this will, the main funda here is fecal microbiota transplantation is nothing but again you are reversing your gut. So it will decrease your osteoarthritis burden. So this is the overall picture, how gut microbiota influences. It involves three axes. One is immune axis. Intestinal barrier is the first immunity. The second immunity will be the innate immunity. And third will be because of your lipopolysaccharides, there will be antigen antibody reaction. It will create your adaptive immunity. In terms of metabolism, yes, energy, diet, and bone. Obviously, bone is because of cartilage. Bone is because of your calcium, vitamin D, magnesium, homeostasis. The third pathway is gut-brain axis. So, because of oxidative stress, there will be increased pain signals. That is, the free nerve endings will release the pain mediators. It will reach your brain. The second one is enteric nervous system. Yes, there will be leaky gut syndrome. And enteric and nervous system is nothing but when your pain signals increases, here the leaky gut syndrome also will increases. This will act in the coordination and helps your gut dysbiosis. The last one already I have explained. So when a ONE comes, there will be a lot of pathogenesis happening here. So because of sensory nerves, there will be decreased, increased release of pain-mediated signals and hence pain results. Progenital cells, it will decrease. Bone remodeling, it also will decrease. Finally, it will go for bone sclerosis at the joint. Hence, your synovitis, joint capsule will stretch, and finally it will give you pain pathway. And last one is cartilage degradation, cartilage hypertrophy. Along with all these things, there is something called meniscus tears. whenever patient comes earlier the age, first always think about the meniscus pathology rather than thinking of subchondral bone pathology. All these things together add to form osteoarthritis knee. So there are different phenotypes for osteoarthritis. One is age-driven phenotype, metabolic phenotype, synovitis-related phenotype, subchondral phenotype, traumatic phenotype, cartilage phenotype. And the main thing what now we are focusing is genetic phenotype that already has been dealt. So all these are all the problems what we find in osteoarthritis knee is cartilage defects, pro-inflammatory cytokines rise, immune cell infiltration, catabolic anabolic imbalance, vascular ingrowth, osteophytes and sclerosis. Because of this, the patient will be getting pain, stiffness, joint space narrowing and synovitis. So what are the treatment modalities to curl up your osteoarthritis knee? First one, first the patient comes, just evaluate the patient whether the patient is having real osteoarthritis or because of meniscus tears. Then go ahead with treating the patient. The main principle is joint strengthening exercises, pain alleviation, gut cleansing and improvisation, joint cushioning effect has to be improved, regenerative modalities to be considered, scaffolding effect, and all these things can be combined and it can be given in a multimodal pathway. Finally, the surgical management and recent advances, nothing but molecular treatment is genetic manipulation and miRNA based therapies. So I thank all my organizations who helped me in pursuing the research in osteoarthritis knee. Thank you.
Thank you, Madhan.
Very well said, Madhan. Very well said. Now next, Rajesh.
Is Vishnu Senthil?
Yes, sir.
Vishnu?
Sir, kindly allow me sharing.
Yeah. Madhan, stop sharing, please.
I stopped, sir, already.
No, not yet.
Vishnu, you start sharing.
Yeah, start sharing, sir. You can say.
Yeah.
See my screen?
Yes.
Sir, good evening, sir, and I thank the convener for giving me this opportunity. So my topic is on disease-modifying osteoarthritic drugs. Coming to the counterproductive horizon, which is the future of the osteoarthritis knee. So coming to the osteoarthritis, as the previous speakers have spoken, so we know that it is mainly involves the cartilage, the synovium, and the subchondral bone. So the current treatment limitations are pain management, physical therapy, and surgery are only available, but not much knowledge is upon the genetic mechanisms, the disease-modifying drugs, the stem cell therapy, and the reversal of the osteoarthritis knee. So what are the current challenges? The current challenges are the challenges which to address the structural degeneration involving the cartilage and the importance to the subchondral bone. And there is also urgent need of treatment that prevent or reverse cartilage loss, mitigate the bone changes and slow the disease progression. So coming to the disease modifying osteoarthritic drugs. So what are these are designed targeting the cartilage degeneration, the inflammation and the synovium. So at the current state, there are no approved disease modifying drugs available yet, and most treatment focus on the symptoms rather than slowing the disease progression. So now we have gone towards the targeted therapy where each and every cytokine and the more and more advances are there. We want to improve the precision medicine targeting bone, cartilage and inflammation to driven the OA phenotypes and reduce the incidence of osteoarthritis. So outline will be involving the bone active agents, the anti-cytokine therapy, involving the enzyme inhibitors, the growth factors. These are the four more primary of the treatment of the disease modifying osteoarthritis drugs, and the most advanced are the gene therapy and other peptides and WNT inhibitors. So coming to this, mainly we have the bone active drugs which involve the bisphosphonates, the bisphosphonates, the strontium and other drugs. And along with the bone active drugs, we also have the anti-inflammatory drugs which are involved in the cytokine, which target the cytokines and the inflammatory molecules. And next we have the group of the enzyme inhibitors we have the nanobodies, the doxycycline, the small molecule inhibitors, and finally, which are the growth factors, which are promising the growth factor family, and which also involves the mesenchymal stem cells. So the disease-modifying drugs mostly target the three main part of the joint. One is targeting the synovitis, next is targeting the cartilage, and third is targeting the subchondral bone. So let us see the overview of how these drugs targeted. So most of the delivery systems are microparticles, nanoparticles, hydrogel system. In microparticles, we have the polymeric nanoparticles, and also through micelles and also through liposomes. So let us see through the commonly used drugs which involve this. So my first group of drugs will involve the subchondral bone. So number one is the bisphosphonates. The most mechanism of action of the bisphosphonate is they target the osteoclast. So this osteoclast they target, and most of these drugs are oral or IV. And the clinical outcome is they increase while the bone turnover markers were reduced, but they failed significantly to show the OA progression. So this is about the bisphosphonates. And next is the parathormone. The parathormone most mechanism of action is they stimulate the osteoblastic activity in the subchondral bone, and also it seems that they have an anabolic effect on the bone, and also influence the chondrocytes and promote the cartilage matrix synthesis and preventing degeneration in OA. The route of administration is subcutaneous injection, also intermittent dosing, and preclinical studies have shown promising cartilage production in parathormone. And next is the strontium ranelate. Strontium ranelate acts by stimulating the osteoblastic activity and inhibiting the osteoclastic activity, and the mode of administration is through oral dose. And strontium ranelate reduced the joint space narrowing and has shown modest effects on pain and making it as a candidate for further research in targeted populations. And next is the calcitonin, which acts on calcitonin. The osteoclast has a direct receptor of calcitonin, so it inhibits the osteoclast and inhibits the bone resorption, and these all drugs act on the bony morphology. And oral administration was there, and now also nasal administration and injectable forms were there. Only the pain management was improved, but no significant improvement in joint space narrowing is seen. And next is the TPX100, which is the precision regeneration cartilage and bone, and they mainly act on the matrix extracellular phosphoglycoprotein. So TPX promotes the osteoblast and chondrocyte differentiation and stimulating in bone and cartilage regeneration. So they show promising targeting areas in cartilage losses, and administration is through intra-articular injection, and ongoing trials are there, and early trials have suggested positive effects on cartilage. And next is the cathepsin K inhibitors. So cathepsin is a protease involved in osteoclast-mediated bone resorption and collagen degeneration of cartilage, and these inhibit the osteoclast inhibition, and which inhibit, and they are crucial in halting the OA progression, and they are in phase 2 clinical trials. Oral administration is done, and the drug name was MIV711. So initially it did not improve pain, but also they have shown reduction in cartilage biomarkers, mainly the telopeptidase X1 and telopeptidase X2. So these all are involved the bone. So next we see about the markers or the anti-inflammatory monoclonal antibodies, which target the synovium or the synovial inflammation or the inflammation pro-inflammatory cytokines. So there are multiple involved depending upon the interleukins, the tumor necrosis factor alpha inhibitors. There are many drugs are seen. This is a subcutaneous dose, and these drugs are showed limited efficacy in OA trials and suggest a need of further refinement in patient selection and dosage. And combined antibodies have been shown to be promising in early clinical trials. So next is the matrix metalloproteinase inhibitors. These matrix metalloproteinase target the enzymes which degrade the extracellular matrix components such as the collagen and proteoglycans in the articular cartilage. And in the clinically, no significant joint space narrowing was seen, and so further investigation is needed in this MMP inhibitors. The next is the aggrecan. Aggrecan is a critical proteoglycan in cartilage. These aggricanases are mainly they degrade the cartilage involved in the cartilage degeneration. So help in using the ADAM-TS antibodies, they are showing promising preclinical early trials. So next is the enzyme inhibitors, namely the syndunistat. So these are inhibit the inducible nitric oxide synthetase. So these inhibit nitric oxide synthetase. Nitric oxide contributes to the cartilage degeneration by promoting the matrix patanoprotease activity and inhibiting the matrix synthesis. So these showed early oral administration and trials, mainly focusing on reducing the anti-inflammatory burden in the joint. So other drugs are doxycycline. So doxycycline, which is a broad spectrum antibiotic, has shown to some amount of inhibition, modulating the inflammatory cytokines and inhibiting the matrix patanoproteinases. But oral administration in early clinical trials, minimum joint space reduction narrowing was seen, but the clinical safety and inconsistent trials and this wide range of toxicity spectrum is also to be taken into studies. So next most important promising things is the growth factors. So coming to the bone morphogenetic proteins, namely the BMP7, they are part of the transforming growth factor beta superfamily, and these all stimulate the chondrocyte differentiation, matrix production, and tissue regeneration. So this is the key, and this has to be further clinical trials, and mostly everything are given intra-articular injection, and more data is required, and this is the key, and this is the future. So next is the sperifermin is a recombinant human fibroblast growth factor 18, and which promotes cartilage chondrocyte proliferation, increases the extracellular matrix, and these fermins is one of the leading candidates of cartilage targeted disease modifying osteoarthritis drugs, and is seen in preserving the cartilage thickness and promising results as seen in these drugs. So other this, as our previous speaker, Professor Rajesh Gupta has shown, this estrogen and other selective receptive blockers like raloxifene and others, they have a modulating turnover on the extracellular matrix. So in post-menopausal female, they have seen to reducing the incidence of osteoarthritis and have a positive effect on the cartilage regeneration. So these are various drugs which are involved, and multiple drugs have been in various clinical trials. Mostly they are targeting the inflamed synovium, the articular cartilage, and also mainly the inflammatory markers. So multiple drugs have been done, and mostly everything are in phase 1 clinical research. So more and more research and more studies are needed to improve and focus on particular drug which will prevent the cartilage degeneration, and we are going towards a regenerative philosophy and reducing to incidence of surgical management. So what is the road ahead? Personalized and localized approach is needed. The future of OA therapy lies in patient-specific localized drug delivery system, and anabolic agents like spurfermin and ADAM-TS inhibitors have been shown superior outcomes when given intra-articularly, and these are shown offering suggestive alternative to systemic treatments. So further studies and further improvements are needed. So our conclusion, it is an ongoing process. Significant advancements in the knowledge of the genetic therapy, inflammatory, and the knowledge of subchondral bone and cartilage sciences have been done. So in developing more and more disease-modifying osteoarthritis drugs, and these drugs have a potential impact in revolutionizing the treatment and offering long-term relief and improving joint function. And this is the treatment and looking towards the future forward. Thanking you for giving me this opportunity, sir.
Thank you, Vishnu.
Very elaborate said.
Yeah. So at one time I was thinking I'm sitting in a osteoporosis webinar, you know. Great. So many new things, you know, are there. Dr. Yogeesh is here.
Yes, sir.
So welcome, Dr. Yogeesh.
Yes.
So it is your turn now. Yeah. To speak on does implant biomechanics help convert early OA need to TKA?
Thank you. Are you able to see my screen?
Yes. Yeah. Go
Great.
ahead.
Great. Thank you very much. It's indeed a privilege to be here, and thank you for accommodating me. I represent the South. I'm a hip and knee surgeon, and I work at Mangalore. Currently, forgive me, I'm traveling, so I'm actually at AIMS Guwahati right now, where we had an event. Anyway, I will go ahead with the talk for today. Early arthritis and total knee replacement is indeed something which is a question and rightly pointed out for this topic, because total knee replacement is indeed getting more and more popular. And there is no doubt that total knee replacement has drastically changed people's quality of lives. As per the WHO, it is the third best surgery on the planet in terms of quality affected life years. And it's only behind hip replacement and cataract in terms of scoring. The quality of life means younger and younger patients with bad affections for various reasons are undergoing joint replacement because they can get back to various activities, as you can see here. We are not shy to let our patients walk around and behave like normal individuals, as compared to before, where there used to be an apprehension associated with knee replacement, where you just limitedly walk, don't sit down, and things like that were being advised. Having said that, there is a lot of change of paradigms. The activity demand means there is further demand on the prosthesis. There is no doubt we have newer and newer prostheses coming in, and with newer and newer prostheses, we are more daring. As there are changes in the fashion industry, there are changes in how we even offer joint replacements. Definitely, we have alternatives, and we are talking today about reversal of OA. So, as beautifully pointed out by Professor Manish Khanna, and there's going to be lectures on DMOADs and what we have heard, there is definitely the question as to whether that, along with things like stem cells, are probably going to be things of the future. But as far as now is concerned, the question is on total knee replacement. Now, what goes and importantly, it is very crucial that we make everybody understand the kinematics of the normal knee. The knee joint is definitely, as we know now, not a pure hinge. And when we say it's a complex hinge, it's much more than that. It actually has freedom of movement in all the three planes. So there is 6 degrees of freedom, which is the maximum degrees of freedom of any two bodies in relation to each other. What makes it more interesting, as you can see to the right of the screen, is that the medial and lateral sides of the joint are rather different. We have known and understood that the medial femoral condyle is larger and the medial tibial plateau is concave. The lateral tibial plateau, on the other hand, is convex. And the lateral femoral condyle, which articulates with that, is smaller. So, what the lateral part of the joint does is there is a rollback movement. There is probably a rollback which was described long term, a long time back when we started with knee replacements. But what we know now is the rollback really predominantly happens on the lateral side, whereas the medial side functions a little more like a ball and socket. Now, we have been trying to replicate kinematics of the knee, but I must say, interestingly, the people who devised the first knee replacements are both here. At the top, you can see John Insull, who is the most popularly associated with modernizing the current knee replacement prosthesis. So, when Insull devised it with Michael Freeman, both of them worked together. Michael Freeman's prosthesis was, in fact, before Insull's. What was popularized more was that when we make knee replacements, or the initial basic knee replacements made were essentially made symmetrical to both the medial and lateral femoral condyles, because we had to create things in a mechanical way. So it was all about making the space of the knee a rectangle and making that rectangle dimensions equal throughout the range of movement. Now, we know from our biomechanics that even though in extension we walk out of the alignment axis, when it comes to flexion, the natural knee joint is not a rectangular space. It is in fact a trapezoidal space. And that is what is further facilitating the rollback and the convex and concave parts of the tibial plateau, as we just saw. So therefore, when we change this to a rectangular space, effectively we are changing normal knee kinematics. Now, different prostheses have come over the years. To the left, you could see the latest version of the insole prosthesis, which has a changing radius of curvature. And as you can see on the top, what has changed to a large extent is now that changing radius of curvature and giving higher flexion was thought about because it exerts more and allows normal flexion. But at the same time, when we are mechanically balancing flexion and extension gaps, we are thinking of them as equal rectangles. Therefore, what we are mentally doing is actually keeping the spaces equal. So therefore, the question, as you see to the figure on the top, whether it should be a single radius knee. So the proponents and long-term studies have suggested that the original design, that the changing radius of curvature gives rise to some kind of mid-flexion instability, but this part has not been proved. So what results is we have various prostheses out there with various ideologies, and depending on the culture you follow, depending on the training, depending on the influence of how these individual factors have had an influence on the surgeon's career, you choose the type of prosthesis. Now, further revolutionizing Freeman's research. Freeman was the man, the second person in the previous picture, who actually gave us studies on normal knee kinematics. And I've been fortunate to have been guided by him in my PhD, where we saw the normal knee kinematics published in the late 90s, early 2000s. The medial side of the joint is pretty much a ball and socket joint. The lateral joint has more rollback. So the prosthesis that you see to the right was the culmination of Freeman's efforts, which is called the medial rotation knee. Now, which of these works? Each of them have got good results, but none of them have shown to have a longer lasting effect over the other in terms of long-term survival. Now we have the younger patient who wants to be more active. At the same time, we want longevity. What we are looking at in the 90s to 2000 to the 2000s, we went on from getting more flexion to mobile bearings. Then we evolved to getting higher flexion knees. We went on to getting more gender specific, because what we wanted is we didn't want metal overhangs and sensitivities particularly. From there have been further studies evolving kinematic principles. When Freeman made the medial pivot, there was the man Scott Banks, who was the authority on studying kinematics with fluoroscopy, with a lot of publications around the first decade of 2000 to 2010, where he then came up with a lateral pivot knee. So this further confuses the matter. What are we getting to the end of the day? Are whatever we do, are we recreating the degrees of freedom? Are we recreating the properties and the viscoelastic curve of normal cartilage? Definitely, we cannot do that. And the restriction for that is the materials. We have gone on from using different types of polyethylene. We've got cross-linked polyethylene today. We've got ceramics, which probably is usable in knees, We haven't gone to using it in India, but there is early data for ceramic and poly, which will probably outlast the metal and poly as it has done with hips. We have gone to cementless designs where we think bone will incorporate, but cementless designs have not given us good long-term outcomes. So all these challenges are still there when it comes to a knee replacement. Today, as a hip and knee surgeon, I can definitely offer without any remorse or apprehension a hip replacement to a young patient, because I know we can make hip replacement and bearings with materials last for probably 50-60 years. Having said that, a knee replacement, I feel worried when I do it in a younger patient, knowing that it will not last as long. So therefore, in a younger patient, I am still looking at alternatives because I know they will probably outlive that knee joint unless they are a senior citizen. Knee replacement still remains a surgery for the senior citizen unless it is inevitable. The satisfaction with knee replacements is still much less, probably because we have not got a normal kinematics recreated. What we definitely know is kinematics of the knee is that of the prosthesis. We might talk about designs, we might get better materials, we are not able to recreate normal knee kinematics. Now, further on from there, I have done a PhD and added some work with the use of computer navigation. What we did was use data and tracking to get us alignment of the knee while we were doing the operation. So we got a range of movement graph. We saw the alignment first time we were always used to looking at alignment only in the coronal plane in full extension. But tracking range of movement allowed us to think about what is happening to that alignment as we flex the knee, as you can see in this graph. So interestingly, what we discovered was that arthritic knees, in terms of a little idea of kinematics that we were getting with navigation, was coming in different patterns. Now, the middle graph, as you can see, is probably what we want to envisage. The middle graph in the column on the right picture, where you want a neutrally aligned knee throughout the range of flexion. But in different types of knees, it is interesting to note how the degree and amount of varus or valgus changes with flexion, and knees also change from varus into a valgus alignment as the knee flexes. This further complicates matters, and therefore we then have to go back to basic balancing principles rather than again thinking whether we will be able to normalize kinematics. Now, early osteoarthritis is very well being documented as an entity, as we know that about 40% of senior citizens in this country are going to get arthritis with problems and have various options for treatment. What probably would be the thing of the next generation, and what previous speakers have very beautifully mentioned, is actually to define early arthritis, pick it up in the early stage, and more importantly, think of whether we can reverse it. So we've got various terminologies and definitions for EOA, but it is definitely defined as an entity. What is the best part is it can be defined on a clinical basis, need not have radiological correlation. So it is defined as affecting the tissues and on pain and disability scores rather than on radiological classification as we go with traditional arthritis. So with the early arthritis, we've got the DMOA days, we've got alternative medicine, we've got exercise, and Prof. Khanna has talked beautifully about the pathophysiological changes. What I have been fortunately able to do is demonstrate, and with a device that we are checking, we've been able to actually predict in 20 to 40-year-olds with reasonable accuracy, with a use of a force tension plate. We've developed an algorithm by which we would be able to, with about 80% accuracy, predict whether a 20, 25-year-old is going to get those arthritic changes. And it is important in this group because we might be able to institute exercise, specifically proprioceptive training, which might make it better. Obviously, when it comes to surgery, which is the main crux of this topic, we have branded and known now that we have a range of joint preservation surgeries. So when you have injuries, treating those injuries, getting ligament reconstruction, meniscal repairs, osteotomy if required, will obviously help and reverse that OA to some extent, prevent it from becoming severe arthritis. So in terms of joint preservation, to add to the armamentarium and put arthroplasty into that armamentarium, I would put it as a range of 3 procedures: from alignment, get alignment, see if you can regenerate cartilage, and then think of, if at all, arthroplasty. So for cartilage, we've got open and arthroscopic procedures. We've got AC, that is chondrocyte, harvest autologous chondrocyte growth, or stem cells by which we harvest the bone marrow. I'm not saying stem cells which are experimental, but autologous bone marrow which can be made to regenerate into cartilage arthroscopically. We've now got studies that artificial collagen-induced chondrogenesis is as good when we actually don't even have to use the bone marrow aspiration. But what I would like to put under joint preservation is, in cases like this, like you can see the alignment view with an absent joint space on the medial side in the young patient, partial joint replacement should come. It is arthroplasty, but at the same time, it is joint replacement as well. So if at all I would advocate arthroplasty for EOA, it is this partial joint replacement which actually will restore normal kinematics if dealt with rightly. So if I have to work out an algorithm and a young patient with early arthritis comes to me, we obviously have to see the clinical symptoms and an MRI to look at the cartilage first. Then go on from there. If it is normal alignment and mild symptoms, definitely the drugs, conservative treatments, and the exercises. However, if the mechanical alignment goes, we then have to think of some kind of surgery. It could be normal alignment, and we have to think about cartilage surgery. Cartilage surgery, cartilage regeneration, however, works for delineated cartilage growth, cartilage loss, or ulcers. It won't work for a uniform cartilage loss, especially when the cartilage loss is both on the tibia as well as the femur side, that is on the reciprocating surfaces. So if the axis is deranged, what we first have to do is correct the axis. So osteotomy, and osteotomy can also be combined with cartilage procedures. We are seeing good results of this. If those don't work, so the more those procedures will work for the more young and probably the more active patient. The still young but less active patient, in my book, is a candidate for partial arthroplasty. Total arthroplasty is still, I would say, not a treatment despite whatever kinematics for early arthritis. So to conclude, there is a lot of technology, but it is how we use it. We have a lot of digital things and things like that, but using it in the wrong way can create a lot of glitches. And unless we have good documented results, we don't really want to go to experimental procedures. We have to think in a very, very logical fashion. We are definitely better off and probably getting better as days go along. Thank you very much.
Thank you.
Thank you very much.
Your last slide said everything, A very nice explanation of a treatment algorithm for early osteoarthritis, right?
Yes, sir.
That was the summary, basically.
Yes, sir. Indeed.
Yeah.
Indeed.
So,
good evening, sir. Can I share my slide? Yeah, I'm here, sir.
Yeah. Welcome, Dr. Abhay, to this fora, IORA fora.
Thank you so much, sir.
Yeah. Please share your slides, please.
I am just looking to share my screen, which is not showing surprisingly. I don't know why. 1 second.
We have one more talk after this by Dr. Ravi. That will be the last talk.
Yeah, surprisingly, I'm not sure why this is not screen sharing.
If it is not sharing, then we can go with it. By the time you work it up, we can put it on last. What do you think, Rajesh?
Let him try for a few minutes. No problem.
Just give me a minute, sir.
Yeah, no problem.
Right. Please, it's your time. No answer.
No idea why it is not sharing.
Abhay, you are on the phone or you are on the
I'm on the screen, sir.
Okay.
1 second. I think we will come around. Sure, why it is screen sharing. Just give me a minute.
Yogesh, you are not still sharing the screen? No.
I have stopped, sir.
Right.
Yeah.
Abhay, go to the bottom, hit it, it might pop up.
I mean, it shared, sir, but I'm not sure why it is not sharing today.
Prof. Abhay, you could probably put it in play mode. Only then people start seeing sometimes. You put it in PowerPoint play mode, the run mode.
Screen and system, other.
You can stop sharing, again restart, then it will function.
I'm trying that, sir.
Abhay, can we start with Ravi's talk in the meantime?
Yes, sir. I think I will do better.
Yeah, no problem. Dr. Ravi, please.
In the meantime, you can send your presentation to someone, maybe Rajesh.
I'll do that, sir.
Ah.
Sir, can you just message me your email, sir?
Yeah.
Thank you, respected members, and I thank you for giving me the opportunity. My job is made simple by previous talks, and we have learned a great deal of things regarding the osteoarthritis. And when I was given the topic, I asked Dr. Jasar what is all about. So he guided me on the topic, and here is the talk. Basically, we are talking about premature conversion of the OA to total knee arthroplasty. Are there perfect clinico-radiological perspectives?
Right, you can go ahead.
So learning objectives today are when it is too premature to do the replacement, and what are the disadvantages of doing a premature total knee replacement, and
Some problem with net?
Yeah, not audible.
And also it is when the joint replacement justified and when it is too late. So considering the total knee arthroplasty, when do we think about it? Obviously, total knee arthroplasty is a common procedure and a cost-effective procedure. Utilization of the limited insurance coverages and panel paid and patient references are there. So insurance definitely has been improving the coverage, and more and more patients are undergoing replacements in these situations. Patient preferences, patient prefer the, preferences and the treatment accesses also impact the replacement surgery, and total knee replacement is effective treatment for the severe arthritis, as we all know this about this. Appropriate timing for doing a replacement, basically, when do we call it a premature replacement? Basically, undergoing a procedure too early may provide a too little benefit for those patients who are undergoing surgical, and there may be a relatively more risks for the younger patients. And when we got a delayed treatment, basically delayed treatment is when there is an increased risk of additional disability and a chronic disease. Comorbidity may be added, and also intraoperative complications can be more, especially with the poor quality of bone as the age advances. So timing is critical, and undergoing a TKR too early or too late leads to adverse outcomes. And patient engagement is the key, and evaluation of the risk and benefit must be done for the patients, and a limited research is there in the quality optimization of a TK timings needs more studies at this point. Osteoarthritis is a leading cause of a disability. About 3.8% global prevalence is expected to increase as the population increases, and non-operative treatment has been already talked about by various techniques where physiotherapy, braces, the lifestyle modification, and medications are used. And obviously, patient with the severe arthritis needs to undergo osteoarthritis, which is highly effective treatment for the procedure. 82% of the TK are estimated to last 25 years, and revision surgeries may be needed in rest of the cases. A rare perioperative complication such as myocardial infarction, pulmonary embolism, and sepsis may be fatal in a few of these situations. And younger patient, there is an increasing, they may need to go replacement, because we have a younger population in India, especially suffering from severe arthritis, and they are in their 40s and 60s. But have a high risk of revision surgeries. And to reduce the need for revision surgeries, TK should be delayed if they have a less pain and disability, but good quality of life is required for a younger patient, especially when they are in their active working life. What are the disadvantages of a premature total knee replacement? There is an increase in the likelihood of revision, and typically 15 to 20 years, there may be revision which may be required in about 20% of patients. Unnecessary risk for surgery like infection, blood clot, nerve damage, and benefits from the surgery may be less noticeable, because their pain symptoms are not that bad as they are when the arthritis is severe and disability is more. Implant wear tear is more, especially when the patients are younger. They tend to do more activity, and obviously physical and emotional toll of the surgery is definitely there in these patients. So this is a modified Escobar appropriateness criteria, which was evaluated to know whether knee replacement is appropriate in a particular patient who's undergoing replacement for osteoarthritis. The decision framework helps a physician to assess the necessity and suitability based on the clinical factors. Factors considered include clinical, functional, and radiographic evidences in this particular study. And what they did, they put up the criteria and the description of the criteria when the severe pain is there, which is persistent severe pain with a significant impact on the quality of life and daily living activities. Functional limitations where difficulty in walking, climbing stairs, and standing prolonged period, and also performing daily activities can cause discomfort. And non-surgical treatment failure, where exhaustive conservative treatments have been tried in these patients, where physical therapy, weight loss, pharmacotherapy in the form of NSAID and intraarticular injections has already been discussed of a different kinds, which have been talked about previous speaker. So radiological criteria, advanced arthritis, obviously X-ray, MRI findings, as MRI also shows a lot of cartilage damage and cartilage degeneration beside the X-ray, which can show narrowed joint space, bone spur, and cartilage loss, which is delineated more with the MRI scans. Typically, age comorbidities as the more and more functional impairment may be there, and assessment of overall health need to be considered with the patients with diabetes and other risk factors. So realistic expectations of the patient are also important, as Dr. Kamat was saying that not all patients are satisfied after the knee replacement. More satisfaction is there for those patients who are undergoing hip replacement. Patients undergo TKA aims to reduce the pain, improve the function, and but not restore the function to the previous pre-arthritic state. So modified Escobar appropriate criteria depending upon the age, level 1, 2, and 3, less than 55, 55 to 65, and more than 65 is level 3. Similarly, knee stability, if level 1, where there is a preservation of the mobility and joint is stable, 5 degree of a flexion contraction may be there, and less than 20 degree of a mediolateral gap is there. And if there is limited mobility in the joint and it is unstable, more than 5 degree of a flexion contracture, or there is a moderate to severe mediolateral gapping in fixed or a fixed 20 degree of deformity, which can be seen. So again, depending upon if it is unicompartmental, bicompartmental disease, or a tricompartmental disease, depending upon the radiological criteria, which talk of Caligrin grade less than 3, 3, and more than 3, 4. So then the levels symptomatology, which is described, which is slight symptoms. These patients may have overall functional loss and function related to the pain. Moderate, when there is a moderate overall functional loss in these patients where WOMAC score is between 12 and 22. When it is intense in these particular situations, the score of WOMAC score can go up to 23 to 33. And in a severe level 4 stage, where the symptoms of the patient are more than 34 on a WOMAC score. So modified Escobar appropriate criteria for a total knee replacement classified the knee replacement in appropriate, in inconclusive, and inappropriate. So what are the patients who fall under inappropriate criteria? These are the patients where the patient has a slight or a moderate symptoms. Radiologic is 3 and less, and the patient is less than 55 years of the age. Similarly, if it is appropriate in this particular situation, the patient is expected, experiences substantial improvement in the pain function and symptoms overall within 2 months of the replacement. And inconclusive is those patients where status is not clear, meaning their symptoms, radiological findings, and recovery outcomes do not provide definitive recommendation. Now, examining the timeliness of the total knee replacement among the patients who are undergoing osteoarthritis. In US, they pooled the data of various studies in a longitudinal cohort, where data was pooled, where the research pooled data from 2 multi-center cohort studies was tracked on a demography, patient reported radiographic and clinical and total knee replacement utilization over 8 years. About 8,000 patients were studied in this, and they classified appropriateness, applied the valid TKR appropriateness criteria, and classified the patients as potentially appropriate, likely inappropriate, and actual TKR utilization. So about in this category, timely TKR was 8% of the patients were considered who have received a TKR in appropriate time. Potentially appropriate, not replaced. These are the patients, about 83% of the patients who were classified potentially appropriate, and they did not undergo a replacement. And premature, TKR, it was 9% were classified to have a premature TKR. So the results were 290 knees, 8% of the total, and 9% of the total knee were classified as timely. And out of 2,833, about 80%, 83% of these patients, or 91% of patients who have which replacement was potentially appropriate, were classified as potentially appropriate but not replaced, and about 9% to 26% of these patients were classified as premature. Of the knee that were potentially appropriate but not replaced, these were 42% of the patients, and compared with the patients who underwent timely total knee replacement, likelihood of being classified as potentially appropriate but not undergone replacement was higher among the black participants, and a premature total knee replacement was lower among the participants with the BMI more than 25 and those who are under depression. So this is the histogram which looks at the classification of the potentially appropriate and who have not gone surgery, and group where they have undergone surgery. And conclusion of the study was that the key observation of substantial number of the patients who had a premature replacement, as well as those who have a surgery potentially appropriate but had not been performed over 2 years. Further understanding is needed. More research is required, especially regarding the group of patients for whom total knee replacement was potentially appropriate but not performed. The risk of premature TKA undergoing was result of little or no benefit was experienced by the patients who were prematurely operated, and the risk of delayed surgery, waiting too long, these patients had a limited physical activity, and risk of a comorbidity was higher. So in summary, clinical criteria, pain intensity, which was higher, especially 7 to 10 out of 10. Functional disability on various scores, which was low functional score. Range of motion, which were deficit, especially 90-degree or less motion because of the contracture. Radiographic evidence is severe joint space narrowing, deformity, and bone damage. Failure of conservative treatment, no relief in 6 to 12 months of a non-surgical treatment. And a severe joint instability or a mechanical issue where is buckling or locking of the knee, which was seen. Risk factors of a progressive total knee arthroplasty within 2 years of presentation of the knee. Identification of the patient characteristics were identified. Data analysis was done on the demography, radiography, and clinical criteria. Multivariate logistic regression was used to determine the risk factors, and it was found that which would help a clinician to guide the factors may influence the patient likelihood who are undergoing a replacement. So decision making regarding the appropriate timings and utilization of the gold standard treatment for the end stage of a knee arthritis. So identification of the key radiographic criteria, obviously those patients who have a grade 4 and severe arthritis, varus alignment is there, and those patients were counseled for a replacement, and findings can aid in trial decision. Development of predictive models, finding can inform the development of a future predictive model of a TKA utilization, optimization of surgical timings, and improvement outcome in these patients. So those patients who had a grade 4 arthritis, patients most severe arthritis were 20 times more likely to undergo a knee replacement. Those patients who had a varus alignment were 13 times more likely to undergo replacement. Excellent predictive power was under the curve, which was about 8.86 of the value. And retrospective analysis identified the key radiographic and anatomical risk factors strongly predict likelihood of the patient undergoing total knee replacement for this particular situation. Here are the major criteria that are considered before the key principles: pain relief, obviously restoring the good function and the longevity of the implant. Summary of the radiological predictors for the TK timings: the complete loss of a joint space, bone-on-bone contact is a very good predictor. Subchondral sclerosis and subchondral cysts, large osteophytes, bone spurs, severe joint deformities, varus valgus, and joint instability, and advanced Callaghan-Lawrence radiological grade more than 3 and 4, and a patellofemoral degeneration. MRI shows extensive cartilage damage and a bone marrow lesions in these patients. Cost effectiveness, again, this was studied for the patients. Analysis of a 50-year-old patients with the severe unilateral osteoarthritis evaluated between conservative and total knee replacement. Analysis showed that these patients were lower lifetime cost. The patients without TK had a total lifetime cost approximately this much, while those who undergone replacement at the age of 50 had a lower lifetime cost. And similarly, improvement in the quality of life and the cost effectiveness procedure, and also decrease in the revision risks. Cumulative risk of a revision decreased from 27% to 10% for the TKA above the age of 70 years of old. So early TKA is preferred for those despite high revision rates, as it is cost-effective procedures which can improve the quality of life in these patients. So in summary, perfect clinical radiological predictive perspective to guide the appropriate, so mild symptoms if patient is having a good response to the medical therapy, intermittent pain, and those patients where there is a preserved mobility and good response to the conservative treatment and a low potential, low patient expectation. These are the patients where, clinically are considered premature to do a TK in these patients. Where knee joint replacement is justified clinically, the severe arthritis where there is a constant disability, pain, discomfort, pain at rest, pain at night. There is a functional impairment because of the deformity, difficulty in climbing up and down, and also standing for a long period of time, range of motion, which is because of the contraction and stiffness in these patients, and instability and mechanical symptoms and impact on the quality of life. When it is radiologically justified, obviously severe joint space narrowing, we have already talked about chondral lesions and deformity, malalignment, tricompartmental disease, and a joint instability and imaging, which can be there. Radiologically, if there are minimal changes, so these are again considered premature, where joint space is preserved, no significant deformity, and localized osteoarthritis. Patient factors, these are age, if less than 60, activity level, mechanical medical comorbidities, and patient preferences. So in summary, when it is too early to do a replacement, it is basically a patient has a manageable pain and there is a good function. There is a mild to moderate osteoarthritis, significant deformity is without significant deformity, and also conservative treatment is still very effective. Those patients where there are severe deformities, persistent pain, functional limitations, severe arthritis, bone-on-bone X-ray, and also joint deformities are there, and the quality of life significantly impaired. When it is too late to do a replacement or too risky to do a replacement, these are the patients where severe muscle atrophy, because in our country, most of these patients, they keep delaying their surgeries, and then they, in the end, when they are, in this particular age group category, these are the patients where we expect not very good results of doing a replacement. It's a very good surgery, as been talked about previous speakers, that it is most rewarding surgery of the century, and obviously it gives not very good results if the patients are delaying their surgery, or it is too risky for these patients to undergo. So these are the patients where particularly quadriceps muscles are weak, muscle atrophy is there for long-standing disuse, and advanced joint stiffness, severe contractures are there, significant limitation, and flexion contractures more than 30° gives a poor results, extensive bone loss, severe osteoarthritis or severe osteoporosis around the knee joint, or stress fractures can give poor results, severe deformity, malalignment, which can give poor results, and infection, because elderly senior citizen, their skin is poor, their healing is poor, their condition and maintenance of the hygiene is not that great, and in that situation the relative risk of infection is higher in these patients, and significant comorbidities. As the age advances, patients may have a diabetes which is less controlled. They may have a cardiovascular problem. They may have a chronic disease, chronic renal disease also. So morbid obesity, more than BMI more than 40. Additional neurological complications, disorders like Parkinson's, stroke, and multiple sclerosis, osteoporosis, and bone fragility fractures, they again make it very complex and difficult for us. So patients, age and life expectancy. So there may be certain contraindications for the patients when there is a limited life expectancy. So in conclusion, TKR is justified when there is a severe chronic functional limitation, radiological evidence of advanced bone-on-bone disease, and a conservative treatment has failed. And it may be too late if the muscle atrophy is there, advanced disease, deformity is there, and significant bone fragility risk is there, and bone quality is very, very poor. So it is a perfect balance between the radiological decision, clinico-radiological decision in the patients with the functional limitation and radiographic severity. TKA should be recommended only when the benefits are clearly outweighs the risk. Thank you very much for your patient hearing.
Wonderful. Wonderful. It's really a great presentation.
So
Dr.
I will try and reshare my screen. Sir is sharing my screen? Okay.
No. You first try. You first try.
Yeah.
Ready. I'm ready. Already ready.
Ha,
Don't
sir. I'm able to share now. Can you
Oh,
see my
thank you.
Oh,
screen?
good.
Yeah.
Great. Great.
1 second. Okay, so thank you very much to Professor Jha, Dr. Rajesh, Dr. Mukherjee, the IORA hierarchy. It is something that is very, very important to what we do as surgeons and as physicians. So we are going to talk about converting certain osteoarthritic knee patients to total knee arthroplasty, and Yogeesh and Dr. Ravi have set the tone to what I am going to speak on. So if you look at the American Academy guidelines on management evidence-based clinical practice guidelines, this document gives 13 pages of non-surgical treatments that are available for osteoarthritis knee, and that has been discussed at large during the previous talks. Some certain group of patients will require surgical treatments, but they will not really be candidates for total knee arthroplasty because they have metaphyseal varus. And these are the patients who will need osteotomy solutions, and which results in realigning the mechanical axis or the load-bearing axis of the knee, and they will do extremely well. So the osteotomy is healed, and these patients will go to painless weight bearing for a significant period of time, provided the surgery is done for its correct indication. However, as you see on this 3-year film, somewhere the disease will become tricompartmental, and somewhere it will go into what we understand as end-stage arthritis. So when you're talking end-stage arthritis, you could have a significant medial compartment disease. You could have a tricompartment disease with severe varus and flexion osteoarthritis, or you could have a valgus osteoarthritis. And all these different situations either need a unicompartmental knee replacement or a total knee replacement. Now, unicompartmental knee replacement can be basically a medial or a lateral condylar knee replacement, or a patellar or a trochlear resurfacing arthroplasty. And if you see these results in the Australian Joint Registry of a UKR being compared to a patellar and a total knee arthroplasty, these results done for the correct indications, these joints have a significant survivorship over almost 20-21 years, which means that this is a procedure which works, and this is a procedure which will benefit the patient if done for the correct indication. Now, what is the correct indication for doing a unicompartmental knee replacement? So we'll talk predominantly of medial compartment disease. So the basic indication is the patient having symptomatic, significant pain, symptomatic disease with significant pain, and having a bone-on-bone arthritis of the medial compartment. These are patients which will have a normal lateral cartilage, intact anterior cruciate ligament function. These are patients who will not have posterior subluxation and posterior wear, which is also a statement of the intactness of the anterior cruciate ligament. And these are patients, when you do valgus stress X-rays on these patients, the joint line will become parallel, as you see on the central X-ray on the left. And these are patients who have a normal MCL. So you need a normal medial collateral ligament, you need a normal anterior cruciate ligament, but you need to have a anteromedial osteoarthritis. As you see here, there is a wearing out of the anteromedial cartilage, and these are patients who will do extremely well with a unicompartmental knee arthroplasty. So as you see, the 64 years old patient who has who tick boxes everything on the criteria of a unicompartmental knee replacement. So the joint line is equalizing, there is medial collateral is intact, the joint is not subluxing posteriorly, it is significantly a bone-on-bone disease, and this patient will do extremely well. And this is essentially normalizing the weight-bearing axis to where it is supposed to be. Now, if you look at symptomatic knee arthritis, 85% of knee osteoarthritis will basically have predominant medial compartment degeneration. So not all of them need a total knee arthroplasty. So what we're looking to do with unicompartmental end-stage disease is restore a joint to its pre-arthritic condition. And what that means is this is performing a true resurfacing of the joint, wherein we do an intra-articular operation so that where there is a constitutional varus, it is restored. So it is just retensioning of the medial collateral ligament, never a release of the medial collateral ligament, because that will lead to alteration of the mechanical alignment of the limb. And essentially, we can do two types of medial compartment replacements. So one is a mobile bearing knee, like the one is a mobile bearing knee from Zimmer, where the essential design between the femoral component and the tibial insert is a ball and socket. So it is a round on round articulation, and between the insert and the tibial base plate is a flat on flat design. So these are fully conforming and non-constrained designs. On the other hand, if you look at the fixed bearing articulation, the femur is essentially a round on flat in contrast to the mobile bearing, and the tibia is a flat on flat. Now, what is the essential difference? Basically, the mobile bearing knees, where the femur is a round on round design between the femur and the insert, they have minimum wear, as has been shown by the JBJS British publications from in the early 2000s and in the mid 2000s. But sometimes because of mobile bearing articulations and incorrectly done procedures, they will go into dislocations. On the other hand, the dislocation rate is very, very low with the fixed bearing designs, but the wear and the shear strain and stresses is much higher, and therefore the rate of revisions for wear is higher by about 10 to 15% in the fixed bearing designs. So both of these designs have their pros and cons. Now, when the osteoarthritis progresses to a tri-compartmental disease, it can predominantly present as a varus flexion entity or a valgus disease. Now, the varus disease, patients can have a less than 10-degree varus, a 10 to 20-degree varus, and a more than 20-degree varus, but significant tri-compartmental disease, as you see this lady, and there is no way we can actually preserve this joint, and she will only do well with a total knee arthroplasty. Quantification of the actual deformation has to be done intraoperatively, and assessing the varus and the flexion deformities for correctability. So the deformation can happen on the coronal and sagittal planes, and they can also happen intra-articularly and extra-articularly. There will be medial and posterior contractures, and the deformity will often be because of stress fractures and bone defects, or invariably a combination of the above. So here is an example of a 61-year-old female, had bilateral stage 4 disease, very significant alteration of the knee society and knee function scores. This is how she's walking, and there is no way we can preserve this joint. Those are her movement films. So definitely a deformation, definitely there is not much movement there. There is a fixed and a correctable contracture. And she underwent a total knee arthroplasty, a posterior stabilized design, where we had to do a reconstruction of the defect and had to protect the reconstruction with a tibial stem. And this patient did very well. And you see here that despite some element of extra-articular deformation, she's walking beautifully, and there is a perfect restoration of the weight-bearing axis of the limb. And this lady has very good range of motion, and she's a very happy patient. So done for the right indication, you can give these patients stable, well-balanced knees, appropriate mechanical alignments, equal gaps, correction of defects, stress fractures, which may need different types of procedures. Now, essentially what we need to understand is, how do you find out which patient needs a total? So there is a lurch, the range of motion is significantly altered. Some of these patients will have significant bone defects, they will have marginal osteophytes, and sometimes they will have stress fractures, which are part of the degenerative process. A very important part of assessment is intra-articular assessment, where we will actually be able to find out the degree of coronal plane and sagittal plane deformity, which is correctable, and that will help us to guide our soft tissue releases according to what is required for a given patient. So balancing a severe flexion varus knee essentially requires clinical assessment to assess coronal sagittal plane deformation, and we need to factor in the radiological assessment based on axis films or scanograms. And that is a beautiful algorithm on what to do depending upon the severity of deformity, the correctability of deformity, and the type of balance a knee will require. Now, coming to another tri-compartmental disease entity where we have the valgus knees. And here is a 51-year-old patient. This is a very, very unique patient. This gentleman has not walked for 21 years and has been bedridden for 21 years. And this is what he presented to us with. He had a fixed flexion valgus knee, and he had a fixed contracture of both the hips. He had a fixed contracture at the spine with kyphosis. So we took him in a staged fashion, did his hips in a staged manner, corrected, gave the hips mobility with the total hip arthroplasty, and then reached on to assessing and managing the fixed valgus deformity, flexion valgus deformity of the knees. And we got a total knee, a constrained type of total knee arthroplasty in our hands. And because he had a hip and a knee with a stem, to prevent an interprosthetic fracture, we had to do a plate, which we tried to avoid by avoiding a stem on the left side and we were able to get away without doing a stem for his left side. So the gentleman who had never walked for 21 years is finally up and about and is an extremely happy human being. So this is almost a 1.5-year-old video, and this gentleman has much better mobility now, although the hips do have a certain amount of heterotopic ossification even now. So the problem is that 10% of these osteoarthritic knees would have a tibiofemoral angle of more than 10 degrees, which is tending towards valgus. And essentially, surgeons are not very familiar with what has gone wrong. So essentially, in valgus knees with tricompartmental disease, it is the tightness of the lateral soft tissue sleeve and the contractures of different structures like the IT band, popliteus, posterolateral capsule, and the popliteofibular ligament, which has to be managed. And these are essentially the LCL and the popliteus would be tight both in flexion and extension. The ITB and the posterolateral capsule will be tight only in extension, and the popliteofibular ligament will be tight only in flexion. So the degree of deformity and the degree of correctability will guide which structures need releasing. In addition, if you see the clinical radiological anatomy of these patients, they will have an asymmetric wear of the femoral condyle. They will have increased posterolateral condylar wear on both the femur and the tibia. The patella can be maltracking, and they could have asymmetry of the patellotrochlear groove. And there would be an external tibial torsion with tightness of the lateral extensor retinaculum. So these deformities will be present in the coronal plane, and some will also be present in the sagittal plane. So you see a flexion deformity on the picture on the right. So some of them will have a flexion valgus, some of them will have an extension valgus. They will be associated with multiplanar deformities of the feet, and some of them will have metaphyseal remodeling of the tibia and the femur over a period of time, especially with the long-standing deformities. So these are the ones who can be classified as having a type 1 with a minimal deformity and minimal medial stretching of the soft tissue sleeve. Type 2 with substantial deformity of more than 10 degrees, which will be associated with a little more attenuation of the MCL and bone loss. And type 3s, which will be associated with severe deformities, with severe osseous deficiencies and incompetent MCL. So that Ranawat classification has now been modified by Dr. Mulaji and Dr. Shetty, and they have classified these knees into type 1 into 6 types. So 1 is a correctable valgus, MCL is okay. 2 is a rigid valgus, MCL is okay. 3 is a valgus with a hyperextension, MCL is okay. Type 4 is a valgus with a flexion and the MCL is okay. Type 5 is a valgus where the medial collateral is incompetent, and these are patients who will need constraint joints. And type 6 are valguses where there is an extra-articular deformity, which will need some kind of added navigation or robotic techniques to deal with these deformities, especially the severe ones. And there is, because there is, it's a significant deformity, the literature is averse to any one technique which will help. But there are, by and large, if you have to follow one principle where you can correct these deformities, and very often they will have excellent survivorship over 10 to 15 years with a properly done soft tissue balancing. So the type of implant to be used in these severe tricompartmental diseases is basically dependent on the degree of deformity, whether it is less than 10, 10 to 20, or more than 20, and on the degree of instability of the MCL. So MCL stable gets a cruciate retaining knee. MCL stability with a 10 to 20 degrees deformity will get a posterior stabilized knee. Where the MCL starts to walk into a little instability, you give him a constraint knee. And where there is a multidirectional instability with a significant deformity of more than 20 degrees, they get a primary hinge knee replacement. So this is a lady, 55 years old, valgus hyperextension, very significant deformity, very significant opening of the medial soft tissue sleeve. Obviously, she was walking into incompetence of the soft tissue sleeve, and we gave her a primary constraint total knee arthroplasty. So, gentlemen, the end-stage arthritis, osteoarthritis, essentially can involve the medial compartment. It can involve the tri-compartment or all the three compartments in the form of a varus flexion deformity, or it can involve cause all three compartment involvement in the form of a valgus deformity. And these are patients who cannot be salvaged with medication or any other therapy. And unicompartmental or tri-compartmental replacement is the way to go in all these patients. Thank you for your time and a patient hearing.
Thank you, Dr. Abhay. I think very clear message on, uni and TK. Very, very clear message from you. Thank you very much.
Thank you so much, sir.
Really, very great talk.
Thank you so much, Dr. Mukherjee.
So we come to the end of our talks. Vishnu, any questions on the chat box?
Right.
I
So,
think there's no questions. So we go for any queries, any questions to the speakers and panel head, sir. Dr. Jha will take over from now.
right. Thank you, Dr. Rajesh. So, we have several papers discussing about non-operative and operative managements. All the presentations are master presentations. We usually say they are master classes. So thank you all the faculty members who have done their job to the best of their capabilities. I think no effort has been spared to make their presentations good. Now, to start with, I'm joined with Dr. Chinmoy, Dr. Nirmal. Dr. Chinmoy, are you there?
Yes, sir. Yes, sir.
So, Dr. Chinmoy and Nirmal. So, Chinmoy, can you start your questions from the first, second, third speaker? Nirmal, you can also join.
No questions in the chat box. But today we had very good discussions. Sir, you can hear me, sir?
Yeah.
Yes.
Carry on.
Audible you are.
So we had very good discussion. And the best part today, what I have observed is because of Rajesh, we could include Professor Ravi Sautha, our Yogeesh, and Dr. Abhay, all these stalwarts with us today in IORA, because we have already good speakers like Madhan, Vishnu, upcoming young good speakers. Of course, Rajesh is always there, and Jha is always there. He's like the main pillar of IORA.
Okay.
And what Sir has already said, that today the papers, they concentrated both on the operative and the non-operative, and some ancillary treatments like your BMAC, then gene therapy, and all those things. So right now, I will ask. I would like to ask. Actually, I'm more of a knee preserving type of surgeon. I don't go for TK. No doubt, Dr. Abhay, are you still there, Dr. Abhay?
Yes, sir, I'm there. I'm there, sir.
Yeah. Acha, Abhay, means you decide for going TK or whether to go for TK or not. You decide on the basis of the these guidelines by Mukherjee and yeah.
So those are
into six
different.
types.
Those are different guidelines for varus and valgus needs. And
Okay.
essentially, if I have to say the three most important reasons to do a total knee replacement in a patient is a patient with end-stage arthritis with pain, and pain. So if the pain has not been healed with all methods of conservative management, including physiotherapy, including medical management, and still the patient's pain is affecting activity of daily living, and it has caused a deterioration of the knee society's functional score to less than 50. These are patients who will do extremely well with a total knee arthroplasty. But even then, those who even qualify for a total knee arthroplasty, I will always counsel these patients that if they are mentally not ready to get an operation, then I will ask them to wait and continue some more period of physiotherapy, because rehabilitation is absolutely vital for them to, recover well to their full potential.
Thank you, Dr. Abhay. And do you also see whether the deformity is mainly in the metaphyseal area of the tibia or in the femur and mainly in the knee? Do you also decide on these factors?
Absolutely, sir. So a deformity in the distal femur causing an alteration of the mechanical lateral distal femur axis, or a deformity in the proximal tibia, a metaphyseal tibial varus causing an alteration of the mechanical medial tibial axis or medial tibial angle. These are patients who will be treated with osteotomy solutions because they do not have an end-stage bone-on-bone cartilage wear. It is only the patient who has a joint disease with an end-stage bone-on-bone disease who needs a total knee arthroplasty. And whether they need a unicondylar or a unicompartmental knee replacement or a total knee arthroplasty depends upon whether the significant wear is on one side of the joint or it is a tricompartmental involvement.
Okay. And
Can I say a word here?
what about the
Yes.
correlation with Fujisawa point? Do you Manish, in your cases you have shown very good results? Do you also correlate with the Fujisawa point?
Absolutely, sir. So the Fujisawa point essentially has to move towards 75 to 100% alteration, and it has to, kind of be part of a significant bone-on-bone disease. Only then these patients will be symptomatically so bad, and the pain will be so disabling that their activity of daily living will go bad. So this is a scanogram and an alignment check. And essentially, the focal point of the disease is something we do for every single patient.
Right. In the
Thank you,
meantime,
Dr. Abhay.
Yogesh wants to intervene. Yes, Yogesh, please.
It was lovely the way Abhay summarized it all. It is the extent of disease rather than the age, and therefore I thought I'll put in my 2 pennies worth. It was like Dr. Abhay said, it is medial compartment, pure medial compartment disease. The rest of the joint is okay. You want to give them a unicompartment. Otherwise, a total compartment. The second, a total knee. The second part, which is so important, Professor Abhay said, was unless they are ready, you don't want to do it. So physiotherapy being such an important part, I have a senior physiotherapist who sits with me in the clinic, and unless they have their prehab, unless they are ready to walk the same day, we really don't want to do this, because otherwise, especially nowadays, we've got a lot of the IT generation getting their parents, because they read all these online advertisements and they think that post knee replacement, a few days later their mother or father will be jumping up and down stairs, and if that person, unless that person is mentally prepared, they're not going to be able to do it. So that part, stressing that part is so important. Secondly, I was wondering, one thing I might add and maybe ask as a question to Dr. Abhay at this point. What I tend to do is I vary between mobile and fixed bearing unicompartmentals. So for younger patients particularly who don't have anteromedial OA, in my practice, I have seen along the southern and coastal part of India, in fact, a lot of untraditional OA, what our textbooks describe, varus arthritis is actually anteromedial arthritis if you look at it from the mechanical point of view. However, I am surprised that over 50% of the patients, I've spent about 10 years on the southwest coast of India now, and over 50% of my patients are not traditional anteromedial arthritis. And I believe this is because of some kind of genetic patterns, a lot of them proportionately have relative joint laxity and a little bit of valgus alignment in their, when they are born, rather than tibia vara, which our textbooks say is common for Indian patients. So for these kind of patients, if they get arthritic, and many of them get arthritic in the medial compartment, surprisingly, at or in their 50s. So if I pick up symptomatic medial joint disease and no other clinical affection in the lateral or patellofemoral joint, I would do unicompartmentals for them. But in those cases, I would do fixed bearing unicompartmentals because they are not typical type of anteromedial arthritis. Would Abhay like to add a little bit on that? Because you spoke.
So absolutely, you covered everything there is to, discuss there. And in my book, basically a pure anteromedial arthritis patient with no other comorbid factors like subtle neurologic problems, significant degenerative spine disease causing lumbagos and pain, radicular pains going down the knees. Those are basically patients who get mobile bearing in my hands, where we start walking into, and obviously, the unicompartmental knees are those patients who fit the modified Cozen and Scott criteria. So we don't follow the original Cozen Scott now. Otherwise, those will lead to only 5% patients getting unicompartmental knees. But we follow the modified Cozen Scott criteria, where it is a full thickness medial cartilage loss with an intact ACL and an MCL, who gets a unicompartmental knee. And those patients whom I see that the lateral compartment is fine, and there is just minimal patellofemoral or lateral compartment disease, and who have those iffy degenerative spine problems or some comorbid issues or very significant poorly controlled diabetes, those patients get a fixed bearing in my hands.
No, what about, okay, great. Now, what I also tend to do is, if there is even a 70 or 75-year-old who has predominantly medial compartment disease, which is symptomatic only with medial joint line tenderness and a good patellar excursion, I would still go and do a unicompartmental in those.
That's
Now,
a very interesting point you made. And actually, I have a beautiful slide from the Australian Joint Registry on my unicompartmental disease talk, which says that, in the 30 to 40, 40 to 50 decade patient, they will have about a 20-year survivorship of about 85%, which starts to drop as the time goes on. But it is the elderly septuagenarians and the octogenarians with unicompartmental disease who are the best candidates for a unicompartmental knee replacement, because they are extremely happy. They post-op rehab is perfect. Their morbidity post the operation is minimal, and they walk beautifully well after the procedure.
I mean,
Right.
that's exactly the point. Risk
Can I
profile.
add some questions?
Yes.
Yes.
Last
Doctor-
intervention from Yogeesh, and then Nirmal poses
Yeah.
his question.
Okay.
No,
Okay, sir.
particularly important to stress that. Thank you, Professor Jha. Particularly important to stress that in the older group, and we've got the results from the joint registry, it's got to be undertaken carefully, because in the 70 to 80-year group, the risk profile is going to be much higher post total knee arthroplasty. So if rightly done and rightly indicated, the outcome of unicompartmental is going to be far, far better. And the important point again with unicompartmental is, because my talk was in relation to kinematics, when you've replaced only one compartment of the joint, that knee is going to have a normal kinematics, whereas no total knee replacement is going to recreate normal knee kinematics, which is why when they tell you in terms of life activities, unicompartmentals don't have clicking problems, don't have activity restrictions, we still allow total knee replacements to sit down. But the activity in terms of people who regularly want to sit down or do their prayers kneeling down is fantastically different with unicompartment as compared to total compartment.
Agree.
That's what I say.
Okay, now Dr. Nirmal.
Sir, I have a small question to Dr. Abhay, then I have one question for everybody almost. I just want to know, Dr. Abhay, very nice
Sir.
presentation. If you see Dr. Ravi's presentation regarding those modified Escobar criteria, the patient you operated who was bedridden for 20 years.
Sir.
And what is his muscle condition and neurological status and how you rehabilitated him, and can you enlighten a little? That will be useful because you have many patients like that.
Okay, so this 20-year-old, 21-year-old patient who had not walked, basically he needed 6 months of extensive physiotherapy before he actually started walking independently. And even before that, we get him around to walking with the help of a walker, with the help of support from the family. But that required extensive quadriceps and hamstring stabilization, strengthening. That required a lot of lower back strengthening. That required a lot of chest physiotherapy. We advise all those who can and want to do pranayam because that allows them to build on their lung capacity, and they can walk longer distances without getting tired. But it took us almost 4 to 6 months before this gentleman actually became comfortable. And another thing I would like to tell you is this patient initially had a paresthesia and a common peroneal nerve transient injury on the right side because he was such a major fixed valgus. And because there was no injury to the nerve, he recovered full function at around 3.5 months. So we got him to walk with a foot drop brace on the right side, with nothing on the left side because the left side did not have anything. And over a period of 6 months, as you saw the video, he was walking normally without any foot drop splints. And definitely there is a difference in how he will walk and a normal osteoarthritic knee, post-total knee patient will walk. But it's an ongoing process. And even today, 1 year and 3 months post his total knee, every time we see him, we emphasize that he has to consistently be in rehab so that his muscle strength keeps on developing.
Right. So Yogesh had also drawn attention to rehabilitative measures pre and definitely post.
Yes.
And that is what you have
Can I ask
qualified.
one more question to Dr. Manish and also Madhan?
Manish is not here, I suppose.
Dr.
Manish, are you
Madhan?
there? Okay.
Manish is not here, sir.
Okay,
He's
fine.
already.
Is Dr. Madhan there?
Madhan
Doctor?
is there.
Madhan, are you here?
No, he's not there again.
Okay.
Okay, then maybe Dr. Yogeesh I'll be asking. Actually, we find a lot of internal tibial torsion patients in our place. For example, I had made a CSR research study where we found that the degree of severity of medial compartmental osteoarthritis correlates very well with the increasing severity, increasing tibial torsion. So how do you correct that during surgery when you plan in tricompartmental and unicompartmental osteoarthritis?
A lot of tibial torsion is also it is definitely there in our Indian patients. We have a lot of patients, in fact, on the coastal side, like I was talking about the dysplasia, with more of persistent femoral anteversion as well, which gives them different kinematics altogether. What I would do is when the tibial torsion is, if it is not associated with a lot of tibia vara, now we are unable to correct too much of rotation in the tibia. So rotational osteotomies are just very theoretical, but if the defect, when as we assess on X-rays, because we are just used to coronal plane assessment, is metaphyseal, the way Dr. Abhay put it very well, then they require definitely an osteotomy. If there is a lot of tibial bowing, then I would be worried about doing a primary TKR, because they definitely would tend to wear that out more. These are people who have some kind of dysplasias. Now, the normal kind of persistent femoral anteversions or tibial torsions, as long as we get a good mechanical, reasonable mechanical, but more importantly, a kinematic alignment, I think they are reasonably satisfied. With my little experience of navigation, navigation and a little bit of now robotics, what I feel is the way literature and the marketing at least is making people think more and more about mechanical alignments only. But we have to get the right importance to soft tissue handling. So soft tissue handling and handling the soft tissues in flexion and extension. With these rotational abnormalities, what we tend to see is the flexion and extension gaps in varus can be very, very different. People, especially the juniors who start taking a arthroplasty in the early stages, would often tend to release a lot medially and resect the tibia less. So if you do a good resection, use basic principles of measured resection for the tibia, and then go on to a gap balancing technique, I think that works better. There's a lot of confusion in literature, particularly more driven by current CT scan assessments and overzealous following of mechanical axis, that often soft tissue releases and the importance to soft tissue releases is given after making the cuts. What I think is important is restrict medial tissue releases in particularly these rotational malalignments, do a tibia first technique, and then use gap balancing principles so that one can handle the femur cuts accordingly. That, in my experience, have given better ability to handle and get better kinematics post-op.
Can
That
I
is the
make a
shortest way I
comment?
can
Can
put
I
it.
make a
Yeah.
comment on that?
Yes.
Nirmal?
Dr. Ravi, let Dr. Ravi
Yeah.
intervene. Yes, Ravi. No,
Good,
you
sir.
are muted.
So mostly the posteromedial, the rotational deformity which comes, it comes primarily because of two reasons. One, that there is definitely varus, as you have already enumerated, and second is probably there is a osteophyte which gets formed on that side. So when you do a soft tissue release and a lateralized tibia little while putting a tibial tray, in that case, after removal of the osteophyte on the posteromedial side, most of the depression which you encounter gets rectified by doing that.
Can I make a comment, sir?
Yeah,
Yes,
sure.
please.
So let any degree of significant internal, so all varices have internal tibial torsion, all valguses have external tibial torsion. So about 10 degrees of internal tibial torsion without bone-on-bone disease is a metaphyseal varus. It needs an HTO. 10 to 15 degrees of internal tibial torsion or even lesser with medial bone-on-bone disease and less than 10 degrees of internal torsion, they get a fixed bearing, not a mobile bearing. If the degree of intorsion is higher, then I will err towards doing a CR knee rather than a unicompartmental knee. And where there is a significant varus, then those are the patients, significant internal tibial torsion of more than 10 to 15 degrees. Those are patients who either have stress fractures, those are patients who've got a varus of more than 15 to 20 degrees, severe varus, and those are who have a flexion and a varus combined disease, and those will need a total knee arthroplasty, whether it is a CR or a PS.
Right. You have
And some of
right.
them will have extra articular deformities, which will need a navigation or a robotic assistance.
You have quantified the torsion along with other deformities and what is to be done. Well, Yogesh, you talked about navigation and robotics.
Yes.
Do you think robotics are out and navigation is again in, or both of them are out?
So I've done a PhD and a lot of work with navigation. Now, if I had to summarize navigation and robotics, navigation holds the jig for you, whereas robotics also makes the cut for you. So essentially, navigation is not as accurate because most navigation or the most popular navigations are imageless. So it depends on what the surgeon marks as points. So navigation, as was initially cited, as it is for a junior surgeon because it makes him understand the axis well, is something I don't agree. Because if the junior surgeon doesn't mark the points on the bones well, those errors will be very much magnified by what the navigation describes as normal alignment. Now, robotics overcomes those errors because robotics essentially is image based. So you have a CT scan, which then the software verifies when the surgeon marks the points during surgery. And the important point of robotics is that it verifies your cuts. So a robot actually makes the cuts for you because you're getting feedback about the cut. Navigation doesn't give you feedback about the cut until you put a trial and it gives you some feedback. The advantage of navigation, however, now I have been on the computer assisted navigation societies right from 2000, from when I did my PhDs, from the earlier generation navigations. But unfortunately, out of people using navigations in our country, if you look at data, this is not published because a lot of people use the navigation and robotics for marketing purposes than for anything else. So navigation and robotics to a large extent was used only for distal femur and proximal tibia cuts. Now, the important advantage of getting these tracking things is actually to understand a little bit about kinematics of the knee. So, if used in the full range, if navigation is used for checking tissue balance, so the earlier generations of navigation with what is called the whole navigation or flexion extension gap balancing navigation, which the first generation systems didn't give, the later generation systems gave, was the ability to test with varus valgus stress and uh, do a little bit of a graph of the range of movement, like the types I'd shown in my slides. Now, that I think is vitally important because it gives a little bit of idea about kinematics of the knee and how the prosthesis will behave during flexion. So, if navigation or robotics, the answer to your question, Professor Jha, was robotics is probably better than navigation because it is tested and it is probably usable by the more junior surgeon, whereas navigation is not. But navigation was making it simpler to check the kinematics and the flexion extension gap. Robotics also has that ability, but not all systems would be able to do that well. So, personally, I am in the process of doing more of gap balancing with a tensioner, which I'm developing and patented, where I am not that worried about the alignment part because with the data on navigation and robotics, we know that with about a 10-15 year experience, anybody will get reasonably accurate. Your outliers of gross malalignment would anyways reduce. If you have
right.
some sort of tracking to check that your mechanical alignment is not out of way, it is more of kinematic assessment and flexion extension gap balancing help that is required, which a few of these systems give, not all of them.
Right. Thank you for making
Dr.
that
Dr.
clear.
Jha, sir, Amitabh
Yes.
has a question.
Yes. Amitabh, And the last question will be from Vishnu. So Vishnu, be ready. Amitabh.
Sir, it was a wonderful discussion. I have been questioned to our most expert replacement surgeons. Now, I don't know you all know or not, there is an Shastho Shati system in West Bengal where the junior most consultant can do an knee replacement, and there is a rampant of knee replacement. Now these patients are us with gross FFD, 30-degree FFD in some cases. Recently, some cases it is 20 to 30-degree rampant. They have, I won't say that that is bad, but due to this free ability of this thing, people have done rampant knee. A lot of knees are coming back to us with FFDs, like 30-degree FFD, 20-degree FFD. Now it's already 2 months or 3 months down the way. Now what to do in these cases? This is my honest question to, like, they have been tried with physiotherapy, passive movement and everything. To our esteemed faculty, how to address and how to deal with it.
So post-replacement residual deformities.
FFD, fixed flexion deformity, sir.
Right.
So rheumatoids and inflammatory osteoarthritis. The rule is correct 1/3. Yeah.
No, these are simple osteoarthritis.
Yeah, so I'm just coming to that. So inflammatory arthritis, we leave 1/3 of the deformity and they will correct beautifully. Osteoarthritis, the dictum is that we correct them on the table. And sometimes you can leave behind, literature says you can leave behind something to the tune of 15 to 17 degrees, and that corrects over time. Now, the patients with residual FFD, if they are not more than 15 degrees, they surprisingly are very happy patients, as other osteoarthritis knee patients are, because their basic arthritis has got taken care of. But a lot of this flexion deformity corrects over time, and they correct maximally by 6 months to a year, and even sometimes a little longer than that. But if you have an unhappy patient with a significant deformity, then one has to look at something which is not right with the total knee replacement.
Right. Professor Shantanu, are you there? Professor Shantanu Lahkar. Yes. Rajesh, please.
Sir, one comment only to Vishnu. He has mentioned about one drug, strontium rallinate, in the treatment part. I think this drug is banned, this drug is not now used because of cardiovascular, things. So, see, this is mentioned in osteoporotic treatment also. So, what do you take on that?
Sir, actually, all these drugs are mostly in the trial phase for osteoarthritis, sir, because most of them, other drugs are in for osteoporosis. It is given, even strontium is given at the very last phase when all other drugs are not there because of the osteoclastic inhibition.
No, basically, Vishnu, this drug is already banned.
Yes, sir.
So trial cannot be done on the banned drug, That is my point.
Yes, sir. Point taken, sir. When later, because
he must have taken it from literature where such studies have been made. But Vishnu, I'm reminded of the instant comment made by Professor Rajesh that I'm into a workshop of osteoarthritis or workshop of osteoporosis. Well, but the message is very loud and clear that all these drugs, bisphosphonates, preferably I would say intravenous ones, and the teriparatide and other drugs. Now we have a different class of bisphosphonate available, which is given intravenous, not available in India, is costly also, and they, when given, they can decelerate, I would prefer the term, decelerate the osteoarthritis. Do you think you defined DMOADs, disease modifying osteoarthritic drug? Ideally, these drugs should show on MR cartogram that the joint space has increased? And do you consider an ideal DMOD drug has been identified?
No, sir, but till now the literature they have not
You
come
were
for an
talking
ideal.
about spirfirmin.
Yes, yes, spirfirmin has showed a positive result. Other than, but there are also in clinical trials only, sir, but not very significant. Only minimal amount of joint space that narrowing reduction was seen, sir. Because there are growth factors like how the mesenchymal state. There are group of growth factors which stimulate the chondrocytic proliferation.
Some of these drugs also had cardiac side effects, and it was because of the cardiac side effects that they were not, they are not so much in practice. Yes, Rajesh.
Sir, spurfin, what he is mentioning is basically, again, it transforming growth factor beta gene, and they are on the trials, nothing is definitive. They are on the trials.
Right.
Sir, one thing, sir, I am
Yes.
in this meeting, and one thing I wanted to know that about when we were in Delhi doing postgraduate in AIMS, we saw lots of ladies having gross osteoarthritis with bowing of the legs, harass deformity, but which is very, very rare till today in our place. So I think, sir, it needs some more genetic study because I think in place of treatment, I think in near future genetic study will help us more for prevention of that disease part. Because even after 46 years, very rarely we see in our community, in our Assamese community, less bowing of the legs rather than what I saw 40 years back in Delhi.
Right. So now it is already 2.5 hours, and we will keep on discussing many facets without joint replacement, with joint replacement. But the whole aim of the webinar this evening was to decipher if we can go for knee preservation surgery. And the task assigned to Professor Ravi, he has answered all the probable questions that when ideally we should go for it. Well, Dr. Abhay, like in his inimitable style, has done real justice to the subject. And Dr. Yogeesh, Yogeesh, are you still here? Right. So,
Yes, sir.
Yogeesh, we wanted to know that out of his experience in the kinematics of the knee, do early transforming the joints to knee replacement should be done or not. And he has rightly shown the cautions that no, joint replacement should be held up not as the first choice. You can think of all others. So if we have to take a consensus as far as the joint replacement is concerned, I would like to know from all the three presentations from joint replacement surgeons in 2 sentences. And Dr. Yogeesh, will you articulate yourself about the consensus? Suppose we have to write a guideline. What will you say?
So if arthritis is severe and is severely disabling with a lot of deformity, particularly when it involves all compartments, age does not matter. We know from long-term results that younger patients with tricompartmental severe rheumatoid arthritis do very well with total joint replacement. So if those criteria are fulfilled, definitely it has got to be a total joint replacement. Having said that, if it is early osteoarthritis, so the second statement would be if it is early osteoarthritis, truly early osteoarthritis with not as much chondropathy, then we have to look at the chondro protective treatments. If there is limited chondropathy, which is cartilage ulcers, we can look at cartilage regeneration. But if it is cartilage loss and limited osteoarthritis, then you can look at partial joint replacements.
Right. Professor Ravi, how will you articulate a consensus?
So basically, pain which is at rest, deformity which is significant, and functional disability which patient is suffering from. So these three main criteria would make patient qualify for replacement. Obviously, on bone, on X-ray, pain at rest and pain at night, and significant day-to-day quality of life which is disturbed for the patient. So these are the patients where they would have to, we will have to consider doing a replacement for these patients.
Right.
Reservation may be
right.
not possible in those patients.
Right. Dr. Abhay, your
So,
final
total
words
joint
of
arthritis, essentially the indications are end stage arthritis, whether monocompartmental or tricompartmental, significantly affecting activity of daily living, where pain is the most important criteria leading to deterioration of knee function score to less than 50. That is a candidate for a unicompartmental or a total knee arthroplasty.
Right. Thank you very much, all the faculty members. We can endlessly keep on going, but I think the message has been driven home when to preserve the knee, when to go for joint replacement, maybe the partial joint replacement or a total joint replacement. Vishnu, we will have to definitely come back to you that with your interventions, I think you can delay joint replacement and a bright future is there. Unfortunately, all these formulations are still not available in India, but for some. Would you like to make a comment finally?
No, sir, the disease modifying drugs are now, everything are in clinical phase trials. So depending upon the further only growth factors, everything further studies are needed, sir.
Right. And final word, yes, Professor Ravi. Professor Ravi. Professor Ravi, you are muted.
Sir, unmute. Dr. Ravi, unmute, please.
So, sir, I just wanted to know what is the role of a already existing huge number of so-called nutraceuticals like glucosamine, rosehip extract, S-adenosylmethionine, curcumin, and so forth. What is the role of these so-called nutraceuticals in osteoarthritis, which none of the conservative treating physicians presenters suggested about. So if somebody can throw light, where
Sir,
do we stand with
literature
these
suggests
molecules?
that curcumin and diacerin, they're all drugs which act on the synovium.
Diacerin is a drug. It is not a nutraceutical.
Yes,
In
sir.
the nutraceuticals, type 2 collagen peptide, then
Curcumin.
protolia, then these
Rosehip extract.
all are said to have role. But I wanted to inform you, sir, that recently there is a Supreme Court order which says the nutraceuticals are bogus. They straight away said this. A Supreme Court order. I was just quoting to this. Although I have my own publication on this nutraceuticals, but
Right.
Supreme
So
Court
you have brought out a very important point that the Supreme Court has intervened.
Yes.
Well, whatever nutraceuticals are there, we will have to sit one evening and again discuss about them.
Yes.
As far as Supreme Court decisions are concerned, bilateral knee joint replacement or bilateral hip joint replacement, they were also banned, but they are practically being done. Any final comment from Yogeesh?
Sir,
Bilateral.
the guideline was it is more risky. That's all. We have had people suing, and the onus on the complications was, and the suing, the successful suing has only been because the patient was probably not very well informed of the complications. Now, the data on it suggests that the cumulative risk of doing both knees at phased points, so that is 1 or a month or two later, is in fact not different from doing them both together. Definitely doing them both together, if it is done in a very hurried manner, gives higher risk of infections. But the other things, so to say it as a practical point, if the patient is medically suitable to have 2 surgeries done at one time, and number two, if they are properly counseled and willing, there is nobody who can, criticize us for that overall.
In
We
fact,
have good outcomes and bad outcomes.
many a times, it is the patients who are more than willing to get it done under same anesthesia.
Precisely, because there are so many advantages to it, which are also cited by literature. So we have to take
Now
it on the individual case.
Right. Now, the last question, if I can say so, is from Dr. Abhay. Dr. Abhay, you talked about spine and knee problems together. So which one first, and how do you proceed?
So essentially, sir, basically what we are saying is one has to try and differentiate between the cause of the pain.
Right.
Now, if the cause of the disabling pain is end-stage knee arthritis, then the patient gets a knee replacement, whichever kind they merit, whether unicompartmental or a total. But if there is a doubt on the significance of the knee pain being contributed by a degenerative spine pathology or any spine pathology, then one has to look at the possible interventions for the spinal pathology before one goes in and does a total knee arthroplasty, because these patients will not have that kind of pain relief as somebody who has a pure a knee problem. Very often, it's the practical life is not so clear, because invariably the 60 plus, 70 plus patients do have some element of degenerative spine disease. But with exercise, with physiotherapy, they do extremely well. And if they have significant knee arthritis, end-stage knee arthritis with significant pain, they do exceptionally well. However, the diseased spine patients with knee arthritis problems who merit knee replacements, we tend to give them slightly more constrained inserts and slightly more constrained joints, especially patients like Parkinson's, patients like systemic sclerosis, patients like who've had recovered hemiplegias, patients who've recovered from who have some myelopathies with significant power, at least a 4/5 power. These are all category of patients who, if they merit a knee replacement, they get a slightly more constrained joint.
Right. Thank you, everybody. And Professor Ravi, I must say, we could not discuss much, but your presentation on the timeline was also so specific, and it framed all the rules when a joint replacement has to be done. Right. So thank you very much. We are really proud of all our faculty members, and we don't want to say good night, but
Thank
yes,
you, sir.
I
Thank you
know
very
I must congratulate Professor Rajesh for conducting this webinar so well. His last words.
Sir, thank you very much. I must thank all the faculty and the panelists for the wonderful, the discussions. At the end, I must also thank the OrthoTV, Dr. Neeraj Bijlani and Dr. Ashok for allowing us to use the platform, OrthoTV. So every time, I ask for that, they are always ready. So we must thank them also.
Right.
Dr. Mukherjee, any concluding comments, please, first?
In concluding comment, I can say this was a wonderful webinar. If we can concise it, if Vishnu can make some points and put it in our web space, that will be very great. One. Number two is I entrust you to do the second webinar by 2 months. Thank you.
Thank
Thank
you.
you.
Right.
Thank you very
Thank you
much.
so much, sir. Good night.
Thank you. Good
Good
night. sir.
night. Good
Thank you.
night.
Good night, sir.
Right.
Good night
Okay, bye.
good night to all the
Good night.
faculties for sparing your time in this Sunday. Good
Thank
Good
you.
night. Thank you, sir.
Right.
Thank you very
It has-
much.
It has
Good night.
almost been 3 hours.
Thank you, Aeropan.
Yes.
Right.
Thank you, sir.
Okay.
One of the most longest webinar IORA has.
Right. Okay.
Thank you, sir.
Bye.
Bye. Good night.
Bye.